introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Your Excellency, distinguished guests, esteemed colleagues, ladies and gentlemen. It is a great honor and privilege to welcome you to this distinguished gathering. We are deeply grateful for your presence and for honoring us with your participation today. We are pleased to commence the session one entitled, Where Are We? Diagnosing Rural Reality. And this session brings together national and international speakers and experts to examine the current realities of rural health, address key challenges, and explore strategies and strategic opportunities for the strengthening population health outcome in rural and remote communities. With that, allow me to begin by introducing our first speaker. Our speaker in this session, Dr. Patricia Kumar. Patricia Kumar is an accomplished rural family physician based on Bihar, India, specializing in comprehensive primary care, infectious diseases, and diabetes and geriatrics. He currently serves as a chair of WONCA, Working Party on Rural Practice, and Rural WONCA, leading the World Organization of Family Doctors effort for rural health worldwide. Dr. Kumar was originally scheduled to join us in person. Regrettably, due to the unforeseen travel constraint, he was unable to join us and in this time to attend this session physically. Nevertheless, he remained keen to participate and has kindly prepared a pre-recorded video presentation entitled Capacity Building in Training, Education, and Research for Rural Health. We sincerely appreciate his commitment and contribution. Let's the videos start.
Namaste and salam. When I first received the invitation to address this prestigious Al-Batin, I was immediately struck by the landscape of a region. It is vast, it is historic, it is beautiful. But as a rural doctor, when I look at vastness, I see something else. I see distance. And in our profession, distance is not just geography. Distance is risk, distance is time, and sometimes distance is the difference between life and death. I am speaking to you today via video, a digital bridge crossing an ocean. And perhaps the format is fitting because the future of rural health is about building bridges across these distances. We are gathered virtually and physically in Harf al-Batin, a place that sits at the crossroads of history. Today it must become a meeting point of solutions. I stand here today not just as a visitor but as the chair of WONCA Working Party on Rural Practice. We fondly call it as Rural WONCA. I bring you the greetings from thousands of rural family doctors from every corner of the globe, from the highlands of Scotland to the villages of India and now to the deserts and hamlets of Saudi Arabia. We all share one truth. The health of a nation is not defined by its most advanced city hospital. It is defined by the most remote clinic. I have been closely following the ambitious Vision 2030 transformation in the kingdom. It is truly inspiring. The shift from a curative model to a preventive model of care, the massive investment in digital health and the Seha Virtual Hospital. These are some of the world-class initiatives. But here is the challenge we must face honestly. Even with the best technology, healthcare is fundamentally human. In Saudi Arabia, as in many parts of the world, we face a maldistribution of hope. We have advanced specialists in Riyadh and Jeddah, but out here in the periphery, we often struggle. We struggle with workforce retention. We rely heavily on expatriate colleagues who are vital, and we thank them. But high turnover disrupts the continuity of care. We struggle with a dispersed population where patients might drive hundreds of kilometers for a consultation that could have been handled locally if the right training existed. We often talk about capacity building to solve this, but what does this actually mean? I'm here to tell you that capacity building is not about bricks and mortar. It's about brain and motivation. It's about taking a young medical student from King Saudi University or a resident right here in Hartford, Bateen, and convincing them that rural practice is not a second class career, but the absolute pinnacle of medical journalism. To achieve this, we cannot just copy urban models, we need to plant a specific strategy. I call this a seed model. To build true capacity in a region like this, we need to focus on four elements. SEED. S stands for skills over theory. Most medical education is designed for the city specialist, but rural practice requires a different set of hands. We need to create the identity of rural generalists. We need to recognize a doctor who can manage a heart attack, deliver a baby, treat a snake bite in the same afternoon as a specialist in their own right. Capacity building means training for this specific versatility. The first T stands for education that is decentralized. We cannot train rural doctors exclusively in the cities. If you train a doctor in a tertiary center where every scan and subspecialist is available a phone call away, you're not training them for rural reality. You're training them for dependency. We need workplace based training. We need to move the medical residency out of the clinics of Hartford Bateen. When a young doctor learns to manage a complex diabetic foot ulcer here with limited resources, they gain a confidence that no lecture hall can provide. The second E stands for evidence, that is local. Currently, most medical research comes from urban academic centers in the West, but rural biology and rural sociology are different, and it's different everywhere. So, why do patients in the eastern province delay seeking care? Is it transport? Is it cultural? We need to research from rural areas by the rural doctors. We need to stop importing solutions and start exporting our own data. We need research from the rural areas by the rural doctors. But I know the reality. A rural doctor sees 50, maybe 60 patients a day. You have the data, but you do not have the time to write the papers. Your observations often die in a filing cabinet. This is where Rural Wonka is stepping in to facilitate research and publication. We are building a research mentorship bridge. Our goal is to pair clinicians, nurses, and other health workers here in Hartford, Bateen, and all over the world with experienced academic mentors from our global network. We'll help you structure data, refine your writing, and most importantly, we will guide you to publication. We are working with open doors with journals to create specific rural tracks and simplify submission pathways. We want to ensure that a case study from desert clinics is as valued as from anywhere else. And we want to turn your daily clinical reality into citations that inform global policy. And finally, D. D stands for digital integrations. We cannot physically place a neurologist in every village, but we can place them there digitally. The model of care in Vision 2030 understands this. Digital tools are the water that allow this seed to grow. It bridges the distance I spoke of earlier. Finally, I'd like to talk about the vehicle, Rural Wonka Institute of Learning. We realize at Rural Wonka that we cannot just talk about these gaps. We need to be a vehicle, we need to find solutions to close them. And I'm proud to introduce you the Rural Wonka Institute of Learning. The institute was born from a simple idea that knowledge should not have any borders. That's why it's an open access platform. The way a doctor in rural Australia manages distance with telehealth, that is relevant to Saudi Arabia. The way in India engage community in health camps, that is relevant to Hafalbatin. The Rural Wonka Institute of Learning is designed to be a global hub for education that is specific for rural context. We are developing certified courses, educational modules, and resource exchange that focuses on rural lens. For the student, it offers a window into the excitement of rural medicine. For the practitioners, it offers upskilling, clinical pearls you can use tomorrow. For the system, it offers a framework to validate and certify rural training centers. My vision for this conference is practical. I invite the leaders of health in Harfalbatin. Let us partner. Let us make this region a pilot site for the Institute's MAP modules. Let us co-create a curriculum that addresses your specific needs, whether it's digestive medicine, non-communicable diseases, or teletriage. Now I'll introduce you to philosophy of grace, the lighthouse. I want to end with a reflection on the philosophy required to do this work. In my own practice and the work I do with our initiative called Grace, I have learned that being a rural doctor is about character. Grace is an acronym for Global Rural Health Action, Collaboration, and Excellence. But let's look at those words very closely. It takes action to stay in remote area when others leave for the city. It takes collaboration to work as a team because you cannot do it alone. And it takes a pursuit of excellence to believe that rural patients deserve the same quality of care as king. I have learned that a rural doctor is more than a prescriber. In a remote village or a desert settlement, the doctor is the lighthouse. When the storm comes, whether it's pandemic or chronic disease crisis or a simple family emergency, the community looks to that lighthouse for stability. By investing in capacity building, by planting the seed of skill and local evidence, and by investing in education through platforms like our Institute of Learning, you are not just staffing clinics, you are keeping the lighthouses burning. To the students who are watching this, come to the rural side, it is where the real medicine happens. To the policymakers, give us the tools and we'll give you the healthy nation. Thank you. Shukran.
Now it's time to move to another speaker. It's my distinct pleasure to introduce His Excellency Dr. Abdullah Asiri. Dr. Abdullah Asiri is a well-known name. Dr. Abdullah Asiri is Deputy Minister for Population Health at Ministry of Health in Saudi Arabia, and where he leads the National Preventive Health Strategies and Population Health Initiatives. He previously served as Deputy Assistant Minister for Preventive Health, and his extensive clinical and leadership experience as a consultant at King Fahd Medical City. Dr. Asiri completed his fellowship in adult infectious diseases at Dalhousie University and has a strong background in clinical research, public health leadership, and health system improvement. His work focuses on advancing national health strategies, strengthening preventive care programs, and improving healthcare quality and population health outcomes at a national level. Dr. Asiri will deliver a presentation entitled Rural Health Reality in Saudi Arabia, Challenges and Opportunities. Dr. Abdullah Asiri, we are honored to have you with us, and we invite you to begin your presentation, and the floor is yours. Please join me to welcoming Dr. Abdullah Asiri.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. أيها الإخوة والأخوات الأفاضل، أتشرف أن أكون معكم اليوم في مؤتمر الصحة الريفية النسخة الثالثة، الذي تقود فيه حفر الباطن هذا الموضوع على المستوى الوطني. وأود في البداية أن أعتذر من الذين لا يتحدثون إلا الإنجليزية، لأني أعددت هذا العرض السريع باللغة العربية، وسأحاول إن شاء الله قدر الإمكان أن أضيف بعض المداخلات الإنجليزية يعني الإخوان الذين لا يتكلمون إلا الإنجليزية يكونون معنا إن شاء الله خلال هذا العرض. نبدأ بمفهوم لماذا وزارة الصحة والمنظومة الصحية تتحدث عن مفهوم الصحة الريفية. الصحة الريفية ونحن لا نتكلم عن نسبة بسيطة، نتكلم عن ما يصل إلى 17% من سكان المملكة العربية السعودية يصنفون على أنهم يعيشون في مناطق ريفية، أي خارج النطاق الحضري الكبير، خارج نطاق المدن الكبرى التي تتركز فيها الخدمات الصحية، أي ما يقارب 5 مليون شخص يحتاجون إلى خدمات الصحة الريفية. لدينا في المملكة العربية السعودية شبكة ضخمة من المنشآت الصحية، وعماد تقديم الخدمة هو مراكز الرعاية الصحية الأولية. رغم التغطية الواسعة ورغم أن أكثر من نصف المراكز بسم الله. الحمد لله. طيب، نعود ونعتذر عن هذا الانقطاع. إذن كما ذكرنا أن هناك أكثر من 5 مليون إنسان بحاجة إلى خدمات الصحة الريفية في المملكة العربية السعودية. ورغم الانتشار الواسع للمراكز الرعاية الأولية وكون أكثر من نصف هذه المراكز يخدم المناطق الريفية، لكن لا يزال هناك تحديات واضحة وكبيرة تواجه تقديم الخدمات بشكل مستدام وبالجودة المطلوبة. ولعل أهم هذه التحديات هو التحديات الجغرافية. مساحة المملكة هي مساحة قارة تتنوع فيها التضاريس ما بين جبال شاهقة إلى سهول إلى هناك فرص ممكن استغلالها بشكل أفضل وأكبر في الصحة الريفية إذا قارناها بالصحة الحضرية أو العيش في المدن الكبرى. الأمر الآخر الذي يواجه الصحة الريفية في المملكة العربية السعودية وفي كل مكان هو الكوادر المؤهلة لتقديم الخدمات الصحية في الريف. نتكلم ليس فقط عن عدد لكن أيضا عن مهارات، فهناك نقص واضح في الإقبال على العمل في المناطق الريفية، واستدامة العمل في المناطق الريفية أيضا تحدي كبير، وفي نوع المهارات التي يجب أن تتوفر في مقدمي الخدمات الصحية في المناطق الريفية. ليس هناك نقدر نقول ليس هناك وجود قوي لبرامج الصحة الريفية في برامج التدريب، سواء في كليات الطب أو في برامج التدريب في هيئة التخصصات الصحية وما في حكمها. تحديات أيضا تتعلق بتقديم الخدمة، خاصة الخدمات العلاجية في المناطق الريفية، تتعلق بالبنية التحتية، سواء البنية التحتية من ناحية إنشاءات، تجهيزات، أو البنية التحتية التقنية. كثير من المناطق الريفية لا يتوفر لها النطاق العريض مثلا لخدمات الإنترنت، وهي أمر لا بد منه، خاصة في خدمات الطب الافتراضي، في خدمات نقل صور الأشعة من مراكز طرفية إلى مستشفيات مركز، إلى مفهوم الرعاية الصحية الشاملة. الرعاية الصحية الشاملة كانت أحد أهم مستهدفات رؤية المملكة 2030، متمثلة في التحول الصحي أو برنامج التحول الصحي، وكان من أحد أبرز مؤشرات الرؤية هو مؤشر التغطية الصحية الشاملة. ومثل ما تعرفون المملكة العربية السعودية حققت في السنوات الأخيرة قفزة مهمة جدا في التغطية الصحية الشاملة، حيث انتقلنا من الدول مرتفعة التغطية إلى الدول المرتفعة التغطية جدا بمؤشر يبلغ 83، وبالتالي أصبحنا في مصاف الدول المتقدمة طبيا فيما يتعلق بالرعاية الصحية الشاملة. وزارة الصحة أيضا تنظر إلى الممكنات الموجودة في برامج التحول كأحد أبرز روافد دعم الصحة الريفية، ولعل من أبرزها هو الطب الاتصالي. لدينا أكبر مستشفى افتراضي في العالم، لدينا تسارع كبير جدا في الخدمات الافتراضية التي تقدمها وزارة الصحة. أصبحت جزء لا يتجزأ من تقديم الرعاية الأولية هو تقديم الرعاية الافتراضية، وحيث يمكن تقديم جزء كبير جدا من هذه الخدمات عن طريق الرعاية الافتراضية. أيضا من أحد الروافد المهمة التي أضيفت أثناء عملية التحول الصحي هو العيادات المتنقلة، وهي مصممة لتجاوز تحديات توفر المباني، أيضا لتوفير المرونة الكافية للانتقال بين المناطق الريفية. كثير من المناطق لا تحتاج وجود دائم لمركز رعاية أولية، ولكن تحتاج إلى زيارات مجدولة بتخصصات معينة وبإمكانات مفصلة على الاحتياج، وهذا هو ما تقدمه مراكز الرعاية المتنقلة، حيث يتوفر الآن أكثر من 60 عيادة متنقلة تخدم المناطق الريفية في المملكة العربية السعودية. من أحد أهم الأمور أو المفاهيم التي تحظى باهتمام كامل في وزارة الصحة وعلى مستوى الدولة هو مفهوم الصحة في كل السياسات، وهو إشراك جميع القطاعات التي لها علاقة بتقديم الخدمة الصحية والاجتماعية في مفهوم تقديم الخدمات الصحية. وهذا هو المفهوم يسمى مفهوم الصحة في كل السياسات، حيث يضمن أن يكون هناك أخذ لاعتبارات الصحية في جميع السياسات التي تصدر من الوزارات، من الهيئات، من جميع يعني الجهات التي لها علاقة مباشرة أو غير مباشرة بصحة الإنسان. بعد استقراء كل هذه التحديات والفرص نستطيع أن نقول أن لدينا مجموعة من المبادرات التي نعتقد أنها ستسهم بشكل كبير جدا في تفعيل مفهوم الصحة الريفية في المملكة العربية السعودية. هناك أمور ذات أولوية قصوى، لعل من أهمها هو الاستثمار عموم المجتمع. هناك فئة من المواطنين والمقيمين لا يستطيعون استخدام الأجهزة الذكية بالشكل الكافي الذي يسمح بتقديم خدمات طبية عبرها، وهذا يحتاج الحقيقة إلى تركيز وإلى يعني مسار للاهتمام به لضمان أن تكون دائرة الرعاية تكتمل بوجود أو محو هذه الأمية الرقمية. معايير الخدمات التقنية أو البنية التحتية للخدمات التقنية مهم جدا أن تكون موحدة لتضمن سهولة انتقال البيانات وعدم وجود مشاكل في التوافق بين الأنظمة التقنية، خاصة فيما يتعلق بالملف الطبي الإلكتروني. تقديم الخدمة المبنية على النتائج أو ما يعرف بالفاليو بيزد هيلث كير ليس مفهوم خاص بالطب الحضري، ولكنه يكون أكثر أهمية في الطب الريفي، بحيث أن تكون المخرجات الطبية هي ما نبحث له، وليس فقط مؤشرات تشغيلية مثلا عدد العيادات أو عدد المرضى أو عدد الاستشارات التقنية، وإنما يكون التركيز على المخرج. ما هو متوسط العمر الافتراضي في هذه المنطقة؟ ما هو متوسط العمر الصحي في هذه المنطقة؟ ما هي معدلات انتشار الأمراض المزمنة التي تؤثر على جودة الحياة أو التي لها دور مباشر في الوفيات المبكرة؟ هذا المفهوم أكثر قابلية للتطبيق في الصحة الريفية منه في الصحة الحضرية. أخيراً أود الختام بالشكر الجزيل لمنظمي هذا المؤتمر والاهتمام والإصرار من حفر الباطن تجمع صحي ومكتب الوزارة وجميع المنظمين لهذا المؤتمر في دوراته الثلاث. هذا يدل على أنه هذا الموضوع في مقدمة الاهتمامات الصحية، يدل على أن هذا الموضوع أخذ حظه من التخطيط والترتيب ليصبح سمة للخدمات الصحية في محافظة حفر الباطن. نشكر اللجان المنظمة على البرنامج العلمي الثري والزاخر وعلى المشاركة الدولية الكبيرة والمميزة في هذا المؤتمر في دوراته الثلاث وخاصة في هذه الدورة. ونتمنى من الله سبحانه وتعالى أن نخرج من هذا المؤتمر بتوصيات محددة تضع اللبنات لاستراتيجية وطنية تتعلق بتجويد واستدامة الصحة الريفية في المملكة العربية السعودية. والسلام عليكم ورحمة الله وبركاته.
Shukran, Dr. Abdullah Asiri. Thanks for Dr. Abdullah for this insightful, very insightful talk. Explore the challenges and opportunities in rural health. Now we will move to a second speaker talking about the National Council for Occupational Safety and Health in COSH, NECOSH Ward, and with His Excellency Engineering Majid Ibrahim Al-Fawez. His Excellency serves as a Secretary General of National Council for Occupational Safety and Health in the Kingdom of Saudi Arabia. In this pivotal role, he leads national efforts to elevate occupational safety and health, especially in the standard through the development of initiatives, frameworks, and guidelines contributing to the creation of a safe environment and healthy and sustainable work environment. With over 23 years of experience, Engineering Majid is recognized as a dedicated leader committed to advancing occupational safety and health. His expertise is rooted in a distinguished academic background in industrial engineering and as an executive master in Islamic financial management, complemented by prestigious leadership certification from Harvard University and the International Institute for Management Development. These qualifications reflect his commitment to implementing innovative, effective solutions in occupational health and safety and related to the occupational rural health in rural communities, which is involved in this talk. Most welcome, join me to welcoming His Excellency Engineering Majid Al-Fawez. And he will talk in Arabic language, and because the constraint of time, there is no questions after the session. Most welcome, Engineering Majid.
Thank you, Dr. حاتم. السلام عليكم ورحمة الله وبركاته. سعادة الدكتور عبد الله عسيري وكيل وزير الصحة للصحة السكانية، سعادة الدكتور تركي المقبل الرئيس التنفيذي لتجمع حفر الباطن الصحي، أصحاب السعادة، الأخوة والزملاء الكرام، السلام عليكم ورحمة الله وبركاته. بداية يسعدني أن أكون معكم اليوم في مؤتمر حفر الباطن الدولي للصحة الريفية في نسخته الثالثة، وهو مؤتمر يجسد تحولا مهما في فهم الصحة الريفية، تحولا من الرعاية إلى الاستراتيجية، ومن العلاج إلى الوقاية، ومن العمل الفردي إلى التكامل بين القطاعات. وعندما نشاهد العرض الذي تم تقديمه من قبل سعادة الدكتور عبد الله عسيري يتضح لنا المفهوم الشامل للصحة الريفية. وعندما نتحدث عن هذا المفهوم فإننا لا نتحدث فقط عن منشآت صحية أو خدمات متنقلة، بل عن منظومة حياة متكاملة تتأثر فيها بيئة العمل ونمط المعيشة وصحة العامل ورفاهيته الجسدية والنفسية واستدامة القوى العاملة. تشير التقديرات الدولية الصادرة عن منظمة العمل الدولية بأن العالم يشهد سنوياً 374 مليون إصابة غير مميتة وأكثر من 2.9 مليون وفاة مرتبطة بالعمل، ما يعني أن عدد الوفيات عالمياً الغير مميت أو عدد الوفيات عالمياً تقدر ب8,000 وفاة يومياً، وأكثر من مليون إصابة غير مميتة بسبب العمل بشكل يومي. وعندما نشاهد الإحصاءات المعلنة عن المملكة العربية السعودية في الجلوبال بيردن ديزيز تشير عدد الوفيات المسجلة بشكل عام إلى 80,000 وفاة تقريباً. وعندما نقارن عدد الوفيات المسببة أو بسبب العمل مقارنة بعدد الوفيات العامة عالميا نجدها تقريبا 5%. فعندما نحسب 5% نجدها تقريبا 4,000 وفية بسبب أمراض وإصابات العمل تحدث سنويا في المملكة، مما يعني أنها يعني خلينا نقول 85% من هذه الوفيات بسبب أمراض مهنية. فنتحدث عن أكثر من 3,400 وفاة بسبب أمراض مهنية، وتقريبا 600 وفاة بسبب إصابات. فهنا نتحدث عن عبء المرض المهني المرتبط بالعمل على القطاعات الصحية. وأؤكد أن هذه الوفيات هي على الأقل، لأن هذا الرقم يعد تقديرا متحفظا لا يشمل بالكامل الآثار الصحية التراكمية طويلة الأمد لبيئات العمل، مثل أمراض القلب المرتبطة بالإجهاد المزمن أو اضطرابات الصحة النفسية أو التدهور الصحي الذي لا يسجل رسميا كوفاة مهنية لكنه يبدأ من موقع العمل. وبالتالي فإن العبء الحقيقي للعمل غير الآمن لا يقاس فقط، وبالتالي فإن العبء الحقيقي للعمل الغير الآمن لا يقاس فقط بالأمراض المهنية، وإنما يقاس بسنوات العمل الطويلة التي يعملها العامل. اليوم تظهر بيانات GBD كما ذكرنا أن أكثر من 70% من الوفيات تعود إلى أمراض غير معدية، وأن الإصابات والحوادث لا تزال ضمن أعلى 10 أسباب للوفاة، كما أن الوفيات بسبب العمل تعتبر ضمن أعلى 5 أسباب لفقدان سنوات العمر المنتجة الدالي، خصوصا بين الفئة العمرية من 15 إلى 49 سنة. وهذه الفئة هي الأكثر وجوداً في قطاعات مثل قطاعات الزراعة والنقل والمهن الميدانية والمناطق الريفية الطرفية. إن الريف لا يستقبل فقط المرض بل يستقبل نتائج العمل غير الآمن، إصابة، مرض مزمن، إنهاك أو احتراق وظيفي. وفي القطاع الصحي تحديداً تشير الدراسات الدولية إلى أن ما بين 30% إلى 45% من العاملين الصحيين يعانون من إجهاد مهني أو احتراق وظيفي، وترتفع هذه النسب في البيئات الريفية بسبب نقص الكوادر وطول ساعات العمل وضغط الخدمة. وهنا يصبح الحديث عن رفاه العامل الصحي ليس ترفاً إداريا بل شرطا أساسيا لاستدامة الصحة الريفية وجودة الرعاية وسلامة المرضى. من هذا المنطلق فإن دور المجلس الوطني للسلامة والصحة المهنية يلتقي مباشرة مع توجهات هذا المؤتمر من حيث معالجة الجذور الوقائية لعبء المرض. ولهذا أطلق المجلس خلال الفترة الماضية حزمة تنظيمية وتحويلية تشكل أدوات عملية تخدم الصحة الريفية بشكل مباشر، من أبرزها لائحة تنظيم العمل بالمهن ذات المخاطر العالية للحد من الإصابات الجسيمة في الزراعة والنقل والمهن الميدانية، بالإضافة إلى لائحة فحوصات اللياقة المهنية للفحص المبكر والوقاية من الانهيارات الصحية المفاجئة، ولائحة اعتماد مقدمي خدمات السلامة والصحة المهنية لضمان جودة التدخلات في الميدان، بالإضافة إلى رحلة تحول رقمي في الرصد والتدريب وتحليل البيانات بما يتيح استهداف المناطق والمهن عالية الخطورة بدقة وكفاءة. كما يعمل المجلس أيضا كذلك على برامج مثل برنامج مزدهر وبرنامج شركاء بهدف تعزيز الرفاه النفسي في مواقع العمل. ونحن نؤمن أن التكامل مع التجمعات الصحية وعلى رأسها أيضا كذلك وزارة الصحة يمكن أن يتحول إلى أثر ملموس من خلال تقليل الإصابات قبل وصولها للمراكز الصحية وحماية الكوادر الصحية جسديا ونفسيا وخفض الضغط على الطوارئ والخدمات الطرفية وتحسين مؤشرات الصحة الريفية على المدى المتوسط والطويل. ختاما وفي هذا الإطار يسرني أن أدعوكم للمشاركة في المؤتمر الدولي الثامن للسلامة والصحة المهنية، والذي نشارك فيه القصص وآليات التعاون واستراتيجيات تطوير السلامة والصحة المهنية على المستوى الدولي، والذي يقام خلال فترة من 27 إلى 29 أبريل 2026 في فندق هيلتون الرياض. كما أن التسجيل في المؤتمر متاح أيضا كذلك لمن يرغب بالحضور عن بعد، ويوفر المؤتمر ساعات معتمدة من هيئة التخصصات الصحية لمن رغب في الاستفادة من هذه الساعات. شكرا لكم والسلام عليكم ورحمة الله وبركاته.
شكرا مهندس سعادة المهندس ماجد على هذه الكلمة. Chief Medical guiding public health strategy for a population of over 16 million of population. Dr. Wajid Ahmed is an academic leader in his field and holds appointment as an adjunct professor at University of Ottawa and Western University. Dr. Ahmed will be speaking on environmental health challenges and population health planning and integrated to rural health. Dr. Ahmed, thank you for joining us today, and we look forward to your insights, and the floor is yours. Please join me to welcoming Dr. Wajid Ahmed.
Thank you. Good morning. It's my absolute pleasure to be here in this beautiful city of الباطن. For centuries, humans are living in a delicate balance with their environment, and we have seen advancement in medicine and science, our understanding and knowledge about the environment and how everything affects our health. More specifically, our understanding about the complex interaction of environment on our health is getting better. And this is giving us an opportunity to protect our environment and also our health. Next slide. So Before I begin, I'm employed by the Ministry of Health, but here I am expressing my views solely and centered on public health science, independent of any official position or policy of the ministry. So this is probably many of you are aware of, the desert does not forgive, it only remembers. And for centuries, the people of this region are living in a delicate balance with this land. Second, we will move on to the assessment part, that how we objectively measure these risks using public health tools. And then we move on to the pathology, the specific biological impacts like syndemics and bioaerosols. And finally, the cure or treatment plan, that how we can move from reactive care to the predictive preparedness. So I'm sure there must be lots of public across the life course. Some of the determinants are very common for all of the population, but others can vary significantly between population groups based on their exposures, which is the environment that is the focus of my talk today. So let's begin with the diagnosis. If we want to in our patient's body, which is our population again. So let's begin our diagnosis by looking at the anatomy of the landscape. And while this map displays Hafar al-Batin, it represents a clinical archetype for many of the rural communities situated in the arid basins. The topography or the rural funnel the land. But then we face rain bombs, which is the extreme intensity events of rain, where a year's worth of rain can be dumped only in 24 hours. For a rural community with limited drainage infrastructures, this volatility is not just a weather element, it's a systemic shock. Now we look at the mechanism of the exposure, how the environment interacts with the population. The soil physics flash flood happen in minutes, leaving no time for evacuations. And then there's the demographic interface. And let's consider the built environment. As the rural town expands, housing often puts into the natural wadi channels, increasing exposures. And crucially, even in these smaller communities, we are continuing to see the urban heat island effect. And as the rural communities grows, the concentration of concrete and asphalt traps leads to a sustained temperatures above 49 degrees centigrade and preventing nighttime cooling. This stagnant heated air degrades local air quality, trapping dust and pollutants right where our families breathe. This is the rural syndemic, a topographic trap, sealed soil, and a heat island microclimate that amplifies every health risk. So after diagnosing the geography, how do we objectively diagnose the impact of the environment on the health of our population? We cannot rely on the anecdotes. We need a surveillance triad. We must integrate clinical data, that is ER visits with syndromic signals, and then furthermore, the environment itself, the heat event is exacerbating these environment, including the urban heat island effect. So a patient doesn't always die of heat stroke, they die of heart failure, which is precipitated by thermal stress or the environmental stress, and we must treat the environment as a comorbidity in this case. Our environmental diagnosis remains incomplete if we ignore the biological reservoirs, and the high density of these biological reservoirs create a permanent zoonotic interface, which is right at the edge of our residential zones. And we must view this proximity as a continuous risk for pathogens like brucellosis and MERS-CoV. We're not just living near animals, we are sharing the microbiome with them. And then secondly, the solar and vegetative defects, which is also can be the green deficit, and the lack of vegetation means we have no natural green lungs to filter the dust we just discussed. And this exposes the population to the full force of the solar radiation. We track the heat, but we often ignore the UV index. And in these open, arid environments, extreme UV radiation is a silent, chronic driver of ocular pathologies like cataracts and dermatological cancers. In summary, our rural environment is biologically active and physically intense. It demands a public health response that looks beyond the humans to the animals we keep and the sun we live under. And then finally, the air itself. In this region, the wind is a vector. We are not just breathing sand, we are breathing bioaerosol that is displaced when the dust carries bacteria, fungal spores, and silica directly to the lungs. And from a public health perspective, we must view every major sandstorm not as a weather event, but as a mass respiratory exposure event to the entire community. We must also think about the indoor air quality and how it will get impacted in rural communities based on how the built environment and their ability to filter out indoor chemicals or toxin. Now that we have diagnosed our patient, our rural communities, and understood how their unique environment is creating new health risks for them, we must move from diagnosis to treatment. And for this, we need a robust framework which is comprehensive, and we use in Ontario a 5-part emergency management cycle, which is not a linear list, but it's a continuous loop of improvement designed to build resilience. Starting off with the prevention, that what the rural communities can do to enforce risk-based land use planning, ensuring that as the towns expand, no new development is permitted in the high-risk natural drainage paths or flood zones. We stop the risk before it's built. And then in the mitigation part, it's about reducing the impact of the risks that are unchangeable. And mitigation is only about infrastructures as policies that comes in implementing a concept which is called sponge city, which helps to absorb sudden rainfall and planting grain belts to filter out the dust from the air before it reaches our homes. And then comes the preparedness, which we do before the storm, which is ensuring that we have a good syndromic surveillance system, which is able to detect any health effects that's coming to us. And when a crisis hits, we move to the response phase, which we actually are trying to save lives and activating our emergency operations centers to provide the care that the community needs. And finally, and critically, is the recovery, which is just returning to the normal and analyzing what happened and what can be done to prevent it from happening again. And if prevention is our goal, we must accept a fundamental truth. The public health does not start yields a 5-fold return on investment, meaning every Saudi Riyal is spent approximately save 5 Saudi Riyal in future healthcare cost. The return of investment can be more depending on the specific type of interventions. So here, what we are seeing is on the left side is the concrete thinking, that how the rural communities are built by default. And then on the right side, we see the sponge city paradigm, which allows us to build cities that are able to absorb some of the impact on the climate. The bottom line is we must start thinking about what kind of big policy changes that we can impact that can help our environment. And then we also need to think about how do we empower the human element. And education, as discussed above before, is our most cost-effective vaccine. We need clear messaging on environmental health hazards in our rural communities, ranging all the way from flood safety, heat management, vector-borne diseases, water quality, and air quality. Clinically, our physicians including public health. We need a climate resilient health system that protects our communities and predicts risks before they become emergencies. Thank you.
Thank you, Dr. Wajid, for this very insightful talk. And now we have a time for one question from the audience. If there is someone has a question for Dr. Wajid, can raise hands. Oh, yep. Dr. Vincent Spilchak has a question. Please give the mic. Where is the mic? Dr. Fahad? Yep.
Can you hear me? Can you hear me there? Great. Thank you very much for that wonderful talk. I'm just wondering if you have an example of where you, back in Ontario, where data has been used to, any projects that have been using data after, say, a climate event, for example, heat, that has been used that you're aware of, that you can share with us.
So I was having a difficulty hearing Vince, but I think you're asking how the data in Ontario is used for preparedness. So we use syndromic surveillance system. We use a system which is called ACES, which is built on identifying the triggers that can predict what kind of impact that will see in the community after any type of incident, whether we are talking about any kind of biological triggers or we see in the extreme heat ones. I think we are getting better. We're still collecting some data, understanding how especially the extreme heat events are being captured and what kind of an impact it's having in the community. But over the time, I think this is an area that we still need to understand, because environmental health is often a forgotten field in how it affects the health of our communities. But definitely we need more correlation between the clinical data, the syndrome, and better understanding of how these environmental factors are affecting the health of the human. Thank you.
Thank you, Dr. Wajid, and thanks for the audience for also the question, because also the constraint of time before the opening official ceremony. Now we'll move to another speaker. We now turn to the critical topic within rural health system. It is my honor to introduce Dr. Saad Al-Battal. Dr. Saad Al-Battal is the CMO, Chief Medical Officer of Chronic Diseases Model of Care in Saudi Arabia, and Chief Medical Officer, Chronic Disease Model of Care and Health Holding Company. He is a consultant of family medicine and chairman of Scientific Council of Family Medicine in Saudi Commission of Health Specialties. He also served as associate editor for Saudi Medical Journal. Dr. Battal will present on the reality of the chronic disease in rural areas. Most welcome, Dr. Saad Al-Battal. Please join me to welcoming Dr. Saad, and the floor is yours.
السلام عليكم، صباح الخير جميعا. أشكر اللجنة المنظمة واللجنة العلمية على هذه الدعوة، وأبارك للجميع نجاح هذا المؤتمر بالنسخة الثالثة. أنا حديثي راح يكون عن البيردن of chronic disease and rural medicine, and I was told that we are running out of time, so I'm going to try to be focused, and I'm going to do this in English. So if there is any questions, I would be available after the presentations for any interaction. These are my objectives. I'm going to talk about what is rural medicine by definition, strategic KPIs, burden of chronic disease, rural medicines, the difference between the rural and urban medicine, and some challenges and successful examples. Now, there are a lot of definitions for rural medicine, but the best one that suits the chronic disease, it's providing healthcare services in low-density populations with limited resources. And some of the definition mentioned that the nearest primary health care centers is more than 30 minutes, and the nearest ER facility more than 1 hour. Now, if we apply that definition, then almost 15% of our populations lay within rural medicine. By doing the proper health services in rural medicine, we will meet significant difference between health determinants in rural and urban areas. Cardiovascular events in rural is almost like the one in urban. It's starting by the age of 35. By the age 45 to 50, 10% of cardiovascular events happen in that age groups. And there isn't a much of significant difference between rural and urban areas. That, of course, goes with mortality. Mortality in to healthcare services, that we need to do something about chronic disease. Big cities in comparison with village and rural areas, and the resources usually is more in cities. However, the community health is better to be manifested in rural area. In rural area, there are low density populations. The family physicians or the primary care should take care and reach out the patients before being diseased and being proactive. And all the 20 clusters have rural areas. 50% of our primary healthcare centers lay in the rural areas. So I would encourage the decision makers to take care about the rural areas, do programs, prevention programs, proactive programs for those population. I just bring this slide to tell you the percentage of obesity and diabetes in Hafr al-Batin in this exercise reach up to 50%. 50% in obesity and diabetes. Prevention, obesity prevention programs in the schools. Doing these programs in rural areas and small towns and villages is more attainable in comparison with the big city. Now, with the challenges, there are a lot of opportunity. of them neurology, ophthalmology, pediatric, dermatology, and all of these specialty can be provided with certain tools, telemedicine, utilizing that tools, telemedicine. Now the internet coverage is almost everywhere in Saudi Arabia. Doing that with a proper setting, having a chamber of consultations and primary care with the advanced specialist in the big city would save not only the time, but even the effort and the proper management for our beloved beneficiaries. There are a lot of tools, otoscope, ophthalmology scopes, ultrasounds, even stethoscope for cardiology consultations, ENT. All of these services can be provided properly by telemedicine once we have the proper setting for providing that. Doing this, now I want to leave the ambition and the creativity and the innovation for you how to do and conduct all of these telehealth medicine and virtual care to your rural medicines and to your rural beneficiaries in rural areas. Thank you.
Thanks, Dr. Saad, for this very informative talk. And I saw a huge number about the screening and the number of chronic diseases, which is contributing, and also even in urban and rural health. So I will open we have a time for 1 and 2 questions. I encourage the audience, if there are any questions, please raise your hand before we open. Yep. تفضل دكتورة.
السلام عليكم دكتور سعد. Thank you so much for your informative lecture.
Please, can you raise your voice? And the control, please take care of microphone.
Dr. Saad, thank you so much for your informative lecture that you presented. I would like just to ask here, one of the slides that you presented, the prevalence of some diseases like hypertensive and diabetes. And what attracts me more, there was one statistic, it exceeds the 100% of the prevalence here in Al-Baطin, like breast cancer and the colorectal. Can we know why the percentage here is exceed the 100% and why it's up to this level of percentage?
You mentioned the screening is less than what you...
It's like, for example, that we find the breast cancer prevalence here, it's 105, if I'm not wrong, more than 100%.
Okay.
And if we go to the colorectal, it's 35%.
Yes.
So what's the reason that come to be below the usual chronic disease like diabetes and hypertension?
Sure. Yes, you referred to my slide at the beginning about the chronic disease burden, and one of them is colorectal and breast cancer. And sadly, the prevalence of breast cancer in Saudi Arabia is getting higher and higher. And although it is just on the female, but it is even more an incidence than colorectal that is happening in both male and female. Now, the incidence of breast cancer in Saudi Arabia happening before the age of 40s. So I strongly recommend, if you have any family history of breast cancer, or the healthcare worker find the breast cancer at young age, to screen the rest of the family and to do the genetic counseling, because that's running in some families. Breast cancer is a huge problem in Saudi Arabia, and it is a burden of the chronic disease as well.
Do you think that the minimize of the physician of obs and gynae, what's mentioned in the one of the other slides, is related to have this high percentage in the breast cancer? I mean that to have no female obstetrician, it's one of the reasons that to have this, And if it is one of the challenges, how it can be improved?
I think the screening is the duty and the business of every healthcare worker, not only the obstetricians, and the responsibility usually in the frontliners, primary care, to encourage ladies to do breast cancer screening. Yeah.
Thank you, Doctor, for this question. I think also we have time for another question. Anyone has question, please raise your hand. Yes. So let me ask Dr. Saad, this is a good opportunity to in terms of the chronic diseases in rural health. What do you think, from your opinion, Dr. Saad, how can we intervene, add some effective intervention that help us to control the chronic diseases, at least to get the numbers, or what are the effective strategies to control the chronic diseases in rural health?
Strongly, I believe, thank you for these good questions. I think empowering primary care in your periphery, in rural areas, would make a huge difference on health for people who's living in the periphery. Primary care is not only a family physician. It's about the community nurse, it's about the health coach, it's about the case coordinator. Having a proper primary care sitting in the periphery, and to be honest, is more important having stronger family physicians in periphery in comparison with the urban areas, that a lot of advanced care is there. Primary care, empowering it in the periphery would save a lot of time and effort and cost, and would ensure healthy society in the rural areas.
Thank you so much, Dr. Saad. Thanks, Dr. Saad, for this very informative and insightful talk. And I want to announce before the official opening ceremony that we encourage all of you to attend 2 workshops at 2 p.m., which is one of the workshops that concentrate about the workforce and also the workforce and the strategies for covering and accessibility of care in rural health. The other workshop entitled of the innovation and digital utilization strategies in rural health. So we encourage the attendees and the audience to join these 2 workshops, at least to build the strategies highlighted for the strategies, and we hope to do it at the end of this conference. So now I'm welcoming you to join the opening ceremony, which is started right now. The opening ceremony is for around 1 hour. The presence of the Prince of Hafr al-Batin, and so they will show the videos and live opening ceremony.
أخرجت من باطنها سبل الحياة، من بقعة إذا تأخى إلى الناهلين من مدرسة خادم المعطاء المملكة العربية السعودية، وبهذا المعنى
لنوره من يشاء
ملايين ونصف إنسان. وهنا في حفر الباطن، حيث بدأت في كل أنحاء المملكة، لأن الرعاية الصحية التي لا تصل إلى كل الصحية الريفية، من زهرة في صحراء إلى رؤية لوطن بأكمله.
يدب كلمة بهذه المناسبة.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. صاحب السمو الأمير عبد الرحمن بن عبد الله بن فيصل آل سعود محافظ حفر الباطن حفظه الله. أصحاب السعادة، ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني نيابة عن زملائي في المجلس التأسيسي للقطاع الشرقي الصحي ومنسوبي تجمع حفر الباطن الصحي أن أرحب بكم في النسخة الثالثة من مؤتمر حفر الباطن الدولي للصحة الريفية. هذا المؤتمر الذي يأتي امتدادا لجهود دلالة واضحة على انتقالنا من تسليط الضوء على قضايا الصحة الريفية إلى بناء توجهات استراتيجية تسهم في رفع كفاءة وجودة الخدمات الصحية وتعزز الاستدامة وتدعم تحقيق العدالة الصحية في المناطق الريفية. الحضور الكريم، أن هذا الحضور النوعي يعكس المكانة المتقدمة التي باتت يحتلها المؤتمر، ويؤكد الأهمية المتزايدة للصحة الريفية محلياً وعالمياً، كما يجسد نجاح المنظمين في استقطاب الخبرات وتبادل أفضل الممارسات. ونفخر بما شهدته جائزة الصحة الريفية من مشاركة واسعة ومتنوعة تعكس تكامل الجهود وتوحد الأدوار بين مختلف القطاعات الصحية. صاحب السمو الحفل الكريم، حرص منظمو المؤتمر على أن تكون مخرجاته ذات أثر مستدام، ويتجلى ذلك في الشراكات والاتفاقيات الاستراتيجية لتطوير وتأهيل الكفاءات العاملة في المجال الصحة الريفية. ويسعدنا في هذه النسخة توقيع اتفاقيات نوعية مع هيئة الصحة العامة وأكاديمية الصحة العامة والمعهد التعليمي للمنظمة العالمية لأطباء الأسرة أونكا للقطاع الريفي، إضافة إلى المجلس الوطني للسلامة والصحة المهنية. كما تميزت هذه النسخة بجلسات الإرشاد المهني وورش العمل المختصة، ومن أبرزها دور طب المناطق النائية التي نفذت بالشراكة مع هيئة الهلال الأحمر السعودي ومشاركة الجهات ذات العلاقة، ودعماً لبناء كوادر مؤهلة قادرة على خدمة المناطق الريفية بكفاءة. في الختام نؤكد أن مؤتمر حفر الباطن الدولي للصحة الريفية يمثل منصة وطنية رائدة لتكامل الجهود وبناء الشراكات وصناعة الأثر، بما يسهم في تعزيز جودة الحياة وتحقيق العدالة الصحية في وطننا الغالي. ويسرني أن أرفع خالص الشكر والتقدير لسمو أمير المنطقة الشرقية وسمو نائبه حفظهم الله، كما الشكر موصول لسموكم الكريم ومعالي وزير الصحة رئيس مجلس إدارة شركة الصحة القابضة والرئيس التنفيذي وقيادات شركة الصحة القابضة حفر الباطن الصحي وجميع منسوبي التجمع على جهودهم المخلصة. نسأل الله سبحانه وتعالى أن يبارك هذه الجهود.
حفلنا الكريم، تسعى وزارة الصحة السعودية لتحقيق الصحة بمفهومها الشامل وعلى كل المستويات للفرد والأسرة والمجتمع، مع العمل على مساعدة المسنين وذوي الاحتياجات الخاصة بما يمكنهم من العيش بشكل مستقل ودمجهم في المجتمع وتوفير الرعاية الصحية الشاملة لهم، وذلك في إطار رؤية السعودية 2030 لتعزيز جودة الحياة والخدمات الصحية ولسعادة وكيل وزارة الصحة للصحة السكانية الدكتور عبد الله عسيري، والذي يشرف هذا المؤتمر نيابة عن معالي الوزير كلمة في هذا المحفل.
وهي رعاية تعكس اهتمام قيادتنا الرشيدة بكل ما من شأنه الارتقاء بصحة الإنسان في كل شبر من أرض هذا الوطن الغالي. كما أحيي سعادة رئيس المجلس التأسيسي للقطاع الشرقي الصحي وزملائي في فرع وزارة الصحة وفي تجمع حفر الباطن الصحي على مبادرتهم لتبني هذا الحراك العلمي والمهني المتميز الذي يسلط الضوء على أحد أهم ملفات الصحة العامة المعاصرة، وهي الصحة الريفية. أيها الحضور الكريم، قد نتساءل لماذا نفرد للصحة الريفية مؤتمراً دولياً؟ والإجابة تكمن في جوهر رسالتنا، فالرعاية الصحية التي لا تصل إلى كل مواطن أينما كان وكيفما كان موقعه هي رعاية منقوصة مهما بلغت جودتها في المدن الكبرى. إن التزام وزارة الصحة المنبثق من رؤية المملكة 2030 يضع الإنسان في مرتكز الاهتمام، ليس كرقم إحصائي بل كحق أصيل في الحصول على أكمل وأجود الخدمات الصحية. إننا نتحدث اليوم عن فئة غالية، إننا ندرك جميعاً حجم التحديات التي تفرضها جغرافيا المملكة الشاسعة. هذا الاتساع الفريد وتنوع التضاريس يفرض علينا تباعداً في المجتمعات الريفية ويتطلب حلولاً مبتكرة وغير تقليدية. لذلك لم تكتفي وزارة الصحة بالنموذج التقليدي للمستشفيات الثابتة ومراكز الرعاية الصحية الثابتة، بل مضت عبر برنامج تحول القطاع الصحي نحو آفاق أرحب، منها التحول الرقمي والطب الاتصالي، حيث كسرنا حاجز المسافات عبر مستشفى صحة الافتراضي والمنصات الرقمية، وسجلنا أكثر من 1,600,000 استشارة طبية في العام، مما أتاح لأهالي المناطق النائية الوصول لنخبة الاستشاريين وهم في منازلهم. كما سيرت وزارة الصحة والمنظومة الصحية أكثر من 60 عيادة متنقلة مجهزة بأحدث التقنيات تخدم المناطق النائية، وهناك خطط طموحة للتوسع في هذا الأسطول لضمان الوصول لكل تجمع سكاني. الحضور الأعزاء، إن الصحة في مفهومها الحديث هي مسؤولية الجميع وليست حكراً على وزارة الصحة، وتطوير الصحة الريفية يتطلب تكاملاً مع قطاعات التعليم والزراعة والبلديات والاتصالات عبر البرامج الرائدة مثل برنامج المدن الصحية، كما يعتمد بشكل أساسي على دور المجتمع المحلي وقياداته في تعزيز الوعي الصحي والمشاركة في صنع القرار الذي يناسب طبيعة المنطقة. ختاماً، إن ما يثلج الصدور في هذا المؤتمر هو الطموح العالي، فهو لا يكتفي باستعراض التحديات بل يهدف إلى رسم ملامح أولى لاستراتيجية وطنية شاملة للصحة الريفية. أكرر شكري للقائمين على هذا التنظيم المتميز وللخبراء والمشاركين الذين شدوا الرحال لإثراء هذا المؤتمر بعلمهم وتجاربهم، ونحن بانتظار توصياتكم ونعد بأن تكون محل الاهتمام والتطبيق لنمضي معا نحو مستقبل صحي مشرق ينعم فيه كل مواطن بالرعاية التي في أي مكان في مملكتنا الغالية. والسلام عليكم ورحمة الله وبركاته.
حضورنا الكرام، إن مؤتمر حفر الباطن الدولي للصحة الريفية هو الفريد من نوعه على المستوى المحلي والإقليمي، وهو يستهدف جميع الممارسين الصحيين والقادة الصحيين والمستثمرين في القطاع الصحي. وهدف المؤتمر الرئيسي تبادل الخبرات المحلية والعالمية في مجال الصحة الريفية، مما ينعكس على تطوير الخدمات الصحية في المناطق الريفية والممارسين الصحيين، والذي ينعكس بدوره على تحسين تجربة المستفيدين، وكذلك وضع المبادرات التي تصنع الأفكار الجديدة كمبادرة الريفاثون الموجهة للأفراد، والتي تجاوزت المشاركات فيها 260 مشاركة من مختلف مناطق المملكة، ومبادرة جائزة الصحة الريفية الموجهة للتجمعات الصحية بالمملكة ومقدم الخدمة الآخرين من جهات خدمية وجمعيات خيرية صحية، والتي تجاوزت المشاركات فيها 40 مشاركة، بالإضافة إلى دعم الأبحاث.
وفي هذا الإطار يواصل تجمع حفر الباطن الصحي جهوده مع شركائه المتميزين في هذا المؤتمر لتقديم نموذج صحي متكامل يرتكز على الابتكار ويقرب الخدمة الطبية من المستفيد، خصوصاً في القرى والمناطق الطرفية. وعبر حزمة من المبادرات الصحية النوعية يعمل التجمع على تطوير الخدمات الصحية ودعم المنشآت الصحية بالكوادر والتجهيزات وربطها بالمنظومة الطبية التخصصية، حيث أطلق التجمع مبادرة الربط الافتراضي مع أقسام الطوارئ بالتعاون مع شركة STC لربط طوارئ مستشفى السعيرة الطرفي بأطباء طوارئ مستشفى الملك خالد العام عن بعد، بما يتيح متابعة الحالات الطارئة ويسهم في سرعة اتخاذ القرار الطبي ورفع مستوى السلامة. وفي إطار تعزيز الرعاية القلبية أطلق تجمع حفر الباطن الصحي وبالتكامل مع مستشفى صحة الافتراضي مبادرة متابعة مرضى القلب عن بعد، تعتمد على أجهزة طبية ذكية تنقل المؤشرات الحيوية للمريض بشكل لحظي إلى الفريق الطبي المختص، بما يسهم في تحسين المتابعة السريرية وتقليل الحاجة للتنويم وتعزيز استمرارية الرعاية، خصوصاً في المناطق الريفية. وفي إطار تطوير الرعاية الصحية أطلق تجمع حفر الباطن الصحي مبادرة صحية نوعية تعزز ربط الأطباء في المراكز الصحية الريفية بالأطباء المتخصصين عن بعد عبر منظومة من الأجهزة الطبية المتقدمة التي تمكن من تقييم الحالة بشكل لحظي، بما يشمل قياس العلامات الحيوية وإجراء السونار وتخطيط القلب والفحص بالسماعة الطبية، بما يحقق تشخيصاً أدق ويرتقي بجودة الرعاية الصحية وييسر الوصول إلى التخصصات الدقيقة في المستشفيات المرجعية، ويخفف عن المرضى عناء السفر. وضمن الجهود الوطنية في خدمة الصحة الريفية، تحضر هنا في حفر الباطن وحدة الأورام المتنقلة التابعة للخدمات الطبية بوزارة الداخلية، استعراضاً لتكامل الجهود الوطنية وما تشهده المملكة من تقدم في إيصال الرعاية المتخصصة إلى المناطق الريفية. وامتداداً للاهتمام بالبحث والابتكار، برزت مبادرة رفاثون ودور اللجنة العلمية للمؤتمر في دعم الأفكار الصحية الموجهة للمناطق النائية وتطوير حلول عملية تعالج التحديات الصحية في الريف. كما أسهم التعاون مع هيئة الهلال الأحمر السعودي في تعزيز الاستجابة الطبية في البيئات الريفية والصحراوية عبر تقديم دورات متخصصة بطب المناطق النائية، دعما لسلامة المجتمع ورفع الجاهزية الميدانية. مبادرات تتكامل وخدمات تقترب وإنسان في قلب الاهتمام. هكذا يمضي تجمع حفر الباطن الصحي وشركاؤه المتميزون في الصحة الريفية لمستقبل صحي أكثر كفاءة لمملكتنا الغالية، وعدالة في الوصول، وجودة حياة تبدأ من القرى وتصل للجميع.
أيها الحفل الكريم، تهدف المؤتمرات الصحية الدولية إلى تعزيز التعاون العالمي لمواجهة التحديات الصحية الناشئة وتبادل الخبرات والأبحاث الحديثة وتطوير سياسات مستدامة للرعاية الصحية. وللمشاركين في المؤتمر كلمة يلقيها البروفيسور بروس.
Thank you very much. Your Royal Highness, the esteemed Governor of Hafra al-Batan, Your Excellencies, colleagues, ladies and gentlemen, distinguished guests. It gives me great pleasure on behalf of my fellow global speakers participating in this conference to extend my highest appreciation and gratitude to Your Highness for graciously patronising this event, which brings together rural experts from around the world under one roof. Your presence today is not only an honour to us, it is also a powerful message that underscores the steadfast commitment of the leadership of this region and of the Kingdom of Saudi Arabia as a whole to human health and every person's right to access high-quality care regardless of where they live. I'd also like to express our deep gratitude to the Kingdom of Saudi Arabia, its government and people for their generous hospitality and warm welcome, which embody the values of generosity and authenticity, foundation for achieving universal health coverage, which is a fundamental human right. In this conference, we witness a unique model. That combines a global vision with local implementation, and striving to elevate the standard of healthcare services in rural areas. The model is not merely a local success, it is a tangible Saudi contribution to the global rural health narrative, demonstrating that sustainable solutions emerge from a deep understanding of the local context combined with a smart openness to the world. Your Royal Highness, as global speakers, we did not come here to deliver purely theoretical lectures. Rather, we came to be partners in dialogue and building. We came to listen as much as we speak and to learn from your experience as much as we share our own expertise. During this conference, cooperative agreements were signed with international rural health institutions, reflecting strategic maturity and a forward-looking perspective. We're here to reaffirm our commitment to supporting this partnership through knowledge exchange, capacity building, and innovation support. We also renew our commitment to Your Highness to support the efforts of the Saudi Scientific Rural Health Association in fulfilling its leading role and continue in its work to advance rural development in the Kingdom of Saudi Arabia and in the Middle East region. In closing, this year's conference theme, From Interest to Strategy, is truly the theme of our time. The era of mere interest has ended. We have seen through Saudi Vision 2030, the noble directives and successful models such as the Hafra al-Bataan Health Cluster, that the Kingdom has indeed moved into a phase of executive strategic planning. As representatives of the global rural community, we see in the Kingdom of Saudi Arabia a promising strategic partner, committed leadership, and ambitious people. We look forward to the outcomes of this conference being a new brick in the bridge of international cooperation and a strong momentum for a pioneering national strategy for rural health, one that befits the Kingdom's stature and the aspirations of its people. We thank Your Royal Highness once again for your generous patronage, and we thank the organisers for providing this opportunity for constructive meeting and dialogue. Together, we can transform rural challenges into opportunities for health and prosperity. May peace, mercy, and the blessings of Allah be upon you. Thank you.
هنا في حفر الباطن حين مد الإنسان صبره قبل يده وقدم حلمه على حيرته وحفر في الصمت حتى تكلم الماء فصار البئر وعدا وصار الوعد طريقا وصارت حفر الباطن موئل القوافل وسكينة العابرين وشاهدا على أن الحياة تصنع بأيدي الرجال. كان خلف كل إنجاز رجال صدقوا ما عاهدوا الله عليه، وحق علينا أن نقول للمحسن أحسنت. يتفضل راعي حفلنا صاحب السمو الأمير عبد الرحمن بن عبد الله بن فيصل وسعادة وكيل الوزارة وسعادة رئيس المجلس وشركاء النجاح. أمان والتي تجاوزت المشاركات فيها 40 مشاركة المركز الأول الخدمات الطبية. المركز الأول الخدمات الطبية بوزارة الداخلية، ويستلمها المدير الطبي الداخلية، ويستلمها المدير الطبي الدكتور أنحي، ويستلمها الرئيس التنفيذي الدكتور حاتم العمري، نظيرة الأساسي الدكتور حاتم العمري، نظيرة الأساسيون للمؤتمر شركة GSK جلاسكو. شركة الجراحات المتقدمة، شركة توطين التقنية. ويقدم تجمع حفر الباطن الصحي تكريما لرئيس اللجنة المنظمة الأستاذ خالد بن مطر العنزي، ورئيس اللجنة العلمية الدكتور عمر المحيميد. نشكرهم على جهودهم في إنجاح هذا المؤتمر، والشكر موصول لفرقهم المشاركة. أيها الحفل الكريم، ختاما بإذن الله تعالى في دروب الخير، والسلام عليكم ورحمة الله وبركاته.
أعزائي الحضور، البرنامج العلمي راح يبدأ على الساعة 11:30. Ladies and gentlemen, we will continue with the scientific program at 11:30. We will now continue with the scientific program and begin our panel discussion, which will explore the role of organization and institution in supporting rural health. Ladies and gentlemen, it is my pleasure to introduce the mediator of the panel, Dr. Khalid Al-Harkan, Chairman of the Board of Saudi Geriatric Society, American Board Certified Family Physician with Geriatric Fellowship, and the Dean at the College of Medicine at Batterjee Medical College. Dr. Khalid Al-Harkan, the panel is yours.
Assalamu alaikum. Good morning, everyone, and welcome to the International Rural Health Conference at Hafr al-Batin. It's an honor to stand before you today as your moderator for this huge gathering, where we aim to discuss pressing challenges and future opportunities in rural health. This session brings together a diverse group of stakeholders, all committed to improving health outcomes for rural populations. Together, we represent a powerful force for change in our communities. Our session will be talking about the role of different organizations and institutions in supporting rural health. For example, we'll be touching on supply chain, health policy, occupational safety and health, and community awareness in rural health. Before we dive into our discussion today, let me introduce my guest panelist, and I'll start with Dr. Abdelmajid Al-Shwai'ir. Dr. Abdelmajid, he is a senior medical director at the National Unified Procurement Company in Saudi Arabia, NUPCO. Dr. Abdelmajid is a Saudi healthcare leader with over 20 years medical experience in family medicine, crisis management, and public health. The second guest panelist is Dr. Taghreed Al-Ghaith, Assistant CEO of the Health Promotion and Improvement in the Public Health Authority, Saudi Arabia. Also, the third guest panelist is Dr. Marwan Al-Bhaisi, occupational medicine consultant at Johns Hopkins Aramco Healthcare. He's an occupational medicine consultant experienced in occupational medicine with history working oil and energy field and aviation medicine. The last guest panelist today is Dr. Ahmed Al-Ammar, the Executive Director of Living Well Initiative, and he is a physician specialized in public health. Let's dig deep now and be more practical. I will start with Dr. Abdelmajid. As an Executive Director or a Senior Medical Director in NEPCO, how do you measure the success of strategic alignment with the logistics in the rural area? And what are the future improvements are you planning to enhance in this alignment?
Thank you so much. At the beginning, I would like to thank you for this invitation, and it's my pleasure to be with you and my colleagues today to discuss about the rural area and medicine, mainly in our particular as the logistics. So In case that's, if you wanted to see it in the beginning, what has been as the challenges is related to the rural area, that we know that the first of all is the geographic place, then is moving forward with the financial background for the rural areas and the budgeting. Then the last things are the biggest issue that's related to the transportation during the rural area about to keep the feeding ongoing. So if we wanted to measure the success, we should to think about also about how we can make the success related to this logistics. First of all, we will moving with a certain of the key performance indicators to measure it, related to the delivery on time, related to the distribution of the logistics among this rural area, and also with the patient satisfaction. It's very important, the rural area, the patient satisfaction is getting one of the challenge, because most of the patients they having moving forward for the big city or the urban city. So if you make these measures as important, if the key performance indicators will be making the performance of the logistics is important, and even with the supplying and the healthcare providers also success and the satisfaction.
Let's be more practical, Dr. Abdul Majid, and have an example of a struggle in the logistics area, and how did you overcome it in a rural area? Let's say, for example, in a remote area in Hafr al-Batin region, and you are facing some logistic problems in supply chain and keeping procurement coming on time and not being expired. Can you give us an example how would you, as an expert in supply chain, how would you make sure that you maintain the right balance between logistic problems and sufficient procurement?
Wonderful, and thank you so much for this question. One of the things is related to the logistics as in the hospitals and the primary healthcare is the distribution of them, and even for the feed and delivery for the equipments and logistics, pharmaceutical and non-pharmaceutical delivery. So one of the projects, innovative projects, is made in NIBCO that we call it as a Mawsul. That it's simply that D2D or the door-to-door, department-to-department delivery. That will keep minimizing all the pitfalls and even the delaying of supply to the hospitals. That will keep the departments will immediately requesting their logistics, and this will be delivered to the department or to the shelf immediately from NIBCO. The other things, that's the distribution of the warehouses.
Yeah.
As distribution is warehouses, or the main warehouses being divided with the big two classes. So do we make it as within a map to make it easy delivery to the hospitals and to the clusters, mainly for the Hafr al-Batin, smoother than before. When we make it with a network, delivery network, and even with a transportation network. That we will, after the implementation of Mawsul in Hafr al-Batin, there is some of changing in a practice, and making the delivery is it's being delivered an easy way.
Thank you so much. I'll talk now with Dr. Taghreed Al-Ghaith as an expert in health policy. Why do you believe rural health really requires a dedicated policy framework? And what makes rural health policy a strategic imperative rather than just an admin choice?
السلام عليكم جميعا. Well, this is a very important question, Dr. Khalid, لأنه when we talk about let's forget about policy and let's so what I was trying to say is that let's forget about the policy and the strategic priority, and let's talk about the rural health. What does it mean? What does rural health mean? It means accessibility to the services and the availability of the services. I can reach the hospital, but is this service available for me? These are two important questions when we talk about providing public health to the population. And rural health This is why rural health is important, because it focuses on accessibility and availability. And as we speak now, these are very important two strategic priorities for us in the healthcare system. I can't think of any tajammu' or any primary healthcare center that we are having here is not having these two pillars, the accessibility and the availability of the services within their talks, especially in the peripheral areas and the rural areas. So this is why it's a strategic priority rather than an operational only.
You raised a very important point regarding the accessibility and availability of the service. But how do you think policy making is really important in rural health? How does rural policy making this point really on the top priority? How can we influence stakeholders through health policy to influence the decision and make this is a priority for rural area, especially when we consider this is a 15% of our kingdom?
تعبناك دكتور عبد المجيد, sorry about this, but when you talk about policy has so many levels. There is a policy what we call regulation, and there are policies that could be translated into mandated guidelines. So when we come to the regulation itself, the policy itself, this is, as we speak now, rural services, and we were having this side talk with my colleagues in the في شركة صحة القابضة in the holding company. And I think, this is where we need to regulate rural health and not talk about it as a privilege. So we need a policy that mandates rural health within the services that is being delivered in the complexes and primary healthcare centers. However, when we talk about the policy, the second level of the policy, and this is where I refer to the guidelines, the mandated guidelines. So if we talk about the services that is being provided, let's say for the diabetes or for the cancer, if we include in these guidelines in the admin, or even not only in the admin, even in the clinical, when we mandate that there should be delivery for the rural areas, then this is where we're talking about the policy or the rural, the role of the policy in the rural services.
Do you think, are we lacking those policies, and you think such a scientific symposium could help design at least an outlines of those policies in rural health areas?
If I get you well, then what you're meaning is that do we need to make sure that these guidelines cover the policies? This is your question.
No, specific guidelines for policies in rural areas. Do we have such in, for example, Public Health Authority or?
Yeah, well, I think the school that I come from, maybe I think that there are other, scientists that might come up with different ideas. But what I call for is to integrate the rural services within the existing policies and not have a separate policy or have a separate program for rural. It has to be integrated. It's a concept that needs to be integrated within each outline, within each guideline. I don't need to produce guidelines for cancer services in rural areas. No, it shouldn't be this way. It should be integrated within the guidelines for cancer control that is, national, and that is implemented on all the levels and not separate. At least this is the school where I promote.
I totally agree with you. You mean integrating those guidelines, for example, into digital health and to other solutions, yes, and emphasize on the role or the importance of those policies in such areas as rural areas. Thank you so much, Dr. Taghreed. I'll now turn to Dr. Ahmed Al-Ammar. As community engagement, we think it's a vital for the success of the health initiatives. And what strategies do you think you have found most effective in engaging rural communities? As we are going from a proactive care, from a reactive care to a proactive care, what do you think is the most important strategies?
السلام عليكم ورحمة الله. صبحكم الله بالخير جميعا. Thank you for inviting me. Glad to attend this. This is my second time to attend the rural forum in حفر الباطن. I think صوتي عالي. نزل شوي تحت. Okay. I think this initiative, the rural forum, is part of the initiatives we are looking for. This forum will help us to understand the rural health, being mature in dealing with the people who's living here in حفر الباطن or any region or rural areas in our country. However, regarding the strategies, we have to consider the participatory approach, the community-led design, not sending the message up, down to the community. We have to sit with the community, understand the belief, what they want, what is their priorities, and design the solutions for them. This way will help us, based on evidence, to succeed in our communication and changing behavior of the people who's living here. This is the advantage of rural health rather than mass communication. What we are doing with such, for example, Live Well initiative, we are targeting all the country, the whole country, which makes it hard to understand what's their belief, what is, how they will respond to our message. But in rural areas, you have the advantage of sitting with the population, understanding their belief, understanding their concern, developing the messages based on their need, and targeting them. Also, we have to consider engaging the local leaders, خطيب الجمعة, شيخ القبيلة مثلا, teachers. We have to consider engaging them and putting them in your side, making them believing in the initiative that we are planning to do. These things, I think, will help us to succeed more with the initiatives.
As an influencer, and you have conducted so many campaigns, at least on the social media, that I personally followed few of them. Do you think there is a unique need in the rural areas compared to the urban areas? Have you noticed any of those needs?
Of course, it depends. Maybe we have to consider even the culture. For example, since I came today from the airports, everyone from حفر الباطن I met, I asked him about فقع, truffle. So this is specific here in this area. People here, they have their own culture. You know, Saudi Arabia is like a big country. So each area has its specific culture, beliefs. When you do mass communication through influencers, through official accounts, it's hard to understand and to change. That's why even in Saudi Arabia, Ministry of Health now, they have clusters, 20 clusters. One of the reasons why we have clusters, why we should have clusters, is that each cluster has their own style, own way of living, own concerns, own health issues. So targeting rural communities, you must have the one-to-one communication, face-to-face communication, and still you can get benefits from the mass communication or social media, but we shouldn't consider it the main way of communicating with the population.
I totally agree. Thank you so much for such an important point. Lastly, we'd like to talk with Dr. Marwan Bhaisi. And what do you foresee as the expected impact?
دكتور العسيري When it comes to occupational health, most of our industry is in rural area and remote area. Actually, in occupational medicine, we call it remote area. Oil and gas sector, as well as mining, is mostly in remote area. And oil and gas sector, mining, catering, offshore, as well as sea transportation. So if we are like in Hafr al-Batin today, and we are 500 kilometers away from maybe Dammam or Riyadh, when you are in the sea, you are thousands of kilometers away from nearest urban area. And you can imagine how challenging it is if you have somebody who got sick in a sea. It has very high implication in terms of money, human health, and human lives as well. So, do we have regulation today in Saudi Arabia? Yes, we do have regulation that regulate remote area clinic. Is there challenges? Huge. And usually people will think about chemical, physical, biological, but I think what's more important here is the psychosocial factors. Being lonely, sometimes drug issue is high among these communities. And if we add number one reason for fatality is commuting actually. People going from urban area to rural area to work, that's number one reason for fatality. So it's not a luxury, it's necessity, and it's a huge necessity. I believe with the regulation as well as the platforms that we have to improve service provision, and that platform is AI powered as well as automated, and it's telemedicine based. So that will close the gap. With time, I think that will help closing the gap, because we do have limitation in manpower when it comes to occupational physicians. Our number is low, but having these digital tools will close the gap with the right regulation. I hope I have answered your question.
Yes, you did. I just want to highlight a very important point that you have mentioned regarding the road traffic accidents that happen on the ways to remote areas, especially for work. Can you give me an example on how regulations from occupational regulations could prevent and improve the rural health communities?
Looking at the point of commuting,
yes,
we have multiple success stories. Like some of oil and gas companies have regulation for workers to stay for 1 week in the work site, so they will not commute every day. At the same time, it's forbidden to use your own car, because at the end of the shift, if you go back to home, you will not be ready to go. So it's a public or let's say mass transportation to work, from work. At the same time, they have to stay for 1 week and live, actually live in that include offshore area. If your question, if I understand it well, will this have implication on the community around? Definitely. Like there is stories from Venezuela, from Latin America, the area where big companies operate its business, they have improvement in public health or population health around, simply because of the healthy worker effect. So healthy worker usually have more coverage, more awareness about health, and this is taken to home usually. So will this affect community? Definitely, it should.
That's a great example. Thank you so much. Back to you, Dr. Abdelmajid. Speaking of the cost now, let me give you an example. For example, a remote cluster have a cost problem related to supplies and procurement. The same problem, it may not be encountered by another cluster close to a port, for example.
Yes.
How do you guys manage the cost in different clusters to make sure we have the right amount and the right access and the right cost?
Yes. As it's been discussed in the previous question related what has been challenges related to the logistics in rural area, we said there is a financial background. It's very important and it's making one of the challenge. That's why we faced most of the rural area globally, they're having a financial and cost impact on their procurements. So the national decree, they created the NIBCO, that's to making the efficiency for all the health institutes. That's why it's been as a bulk of health institutes is working together to have a one tender. It will be minimizing all the pitfalls and the risk on the rural area and small institutes. Yes, it will be as a union between the big institutes and the small institutes as a one procurement bulk tendering. That will making a proper, efficient supply to the rural area and with a good cost too. It's also been aligned with their strategic and is making efficient amount. It can be circulated again with other investing in health rural areas too.
Yeah, can you give me more like a practical example on how we make sure we have sustainability in such remote areas in terms of cost? Have for example, you guys done any initiative, especially for remote areas, to make it more sustainable in terms of the cost?
Yes. Most of the tendering and procurements has been as a one tendering for almost of the clusters. That is making efficient among the cost and making a continuous of the sustainability. Also the redistribution of the amounts among all the kingdom with more than 11 big warehouses has been available to make a secured of a sustainable supply of all the health logistics to the health institutes. This will make this efficient among the logistics part. It's not on only this one, it will be evaluated on the value. Value, that's meaning it will be included main of the elements to measure it. It's not necessary to be as a financial, it will be as maybe patients' satisfaction, healthcare delivery, and even for the time of the delivery with the value outcome about this product when it's been available properly.
Great answer. Thank you, Dr. Abdelmajid. Back to you now, Dr. Taghreed. And would like to highlight another point regarding the policies. You think, as an expert and health advocate and policy maker, what do you think is the most important aspect in the policies that we have to concentrate on in the rural areas and the remote areas and could really influence the rural population health?
Well, the most important policy, given my current position in Wiqaya, which is the Public Health Authority, are the policies that are related to NCDs, which is the non-communicable diseases. And then if we zoom into these NCDs, we'll have to focus on the NCDs, and this is related to your comment, Dr. Ahmed, about if we're going into a mass campaign, then what is it that I'm targeting? And then I just wanted to clarify to you that we need to go back to data, especially the mortality data. What are, the NCDs that is related to the mortality of most prevalent mortality causes in the population? And here, when it comes to the NCDs, it's we do know that diabetes, hypertension, and the smoking are very much highly related to the surging numbers of mortalities among the population. So the policies of the rural health should focus on these and also on the child and the maternal services. This is where the rural health should be focusing now all over the kingdom, yes, but even in certain areas rather than other areas. It is the data that should be leading us. Where do we put the money that we need, the financial cost, where does it go when it comes, you know, to the logistics, and what is it we want to focus, or even when it comes to the mass campaigns.
Excellent. Thank you so much. Now, Dr. Al-Ammar, as we talked about community campaigns and how those rural areas really require a unique programs tailored to their needs, tailored to their culture, tailored to their important aspect or important non-communicable disease in their communities. From your experience, what do you think we can do as a community awareness campaigns, something special for rural areas other than, could be different than urban areas?
It depends. We have to have data, as Dr. Tagreed mentioned. It depends. I think even rural areas in Saudi Arabia, there is differences in their needs based on the available data or understanding of the community, or maybe we can use the data from the primary healthcare centers, screening programs in the rural area. It will help us on designing the much needed programs. However, the area that I want to highlight is what people need. It's easy. When we design the initiative, we can design the need based on, as what we mentioned, sitting with the community, local leaders, understanding and prioritizing. The point is, sometimes these kind of initiatives failed because maybe we don't make the local leaders feeling that they are co-owner for these initiatives. The on-ground activation needs to, if they don't believe, you cannot do everything alone. The alignment is much needed in on-ground activation. On social media, on mass communication, it's easier. You can develop the content, it will go viral. But on ground, you need to make sure that you have believed leaders. Also, you need to educate them, give them the messages that you need to deliver, train, and also we have to monitor the programs and correct to monitor the programs and correct accordingly during the activation period.
Totally agree. Engaging, I think locally. We have an implications of those regulations and how those regulations and how those regulations really helped.
Definitely. We do have two kinds of regulation, statutory and risk-based. So statutory is compulsory regardless of the task. As far you are, let's say, pilot, there is health check for you, there is fitness for duty on periodic basis. It's the same for people working offshore and seafarers. And it's actually regulated by ILO, International Labour Organization, and it's fundamental part of our fitness for duty guidelines by National Council of Occupational Safety and Health. It's already out, and it will be binding within less than 1 month, maybe in March. So there is special regulation for people working offshore as well as seafarers. It's very tight, actually. It has a special format. Physician doing this physical should be trained. Being a doctor is not enough. He needs to be trained in certain, like specifically of this kind of fitness for duty evaluation. Aerobic capacity for those doing diving. So there is specific regulations, never been there at the national level before, unfortunately, until recently with the council. And again, the platforms, enabling to provide this service is in the way.
Thank you so much. That's a very helpful answer. Lastly, Dr. Abdul Majid, is there a take-home message that you want to give?
Part of planning and demand. It's very important when we want to do it as a part of a projection, and we can have it as a conclusion later on, inshallah. And we can have it as a conclusion later on, inshallah.
Excellent. Thank you so much. Now, Dr. Taghreed, again, a take-home message from your position as a health policy advocate. Do you want to tell the policy makers about rural health?
Well, thank you so much. I think, again, I'll repeat what I have said, in the beginning. Rural health is a concept that should be integrated with every single policy that we produce, every single guideline that we produce, every single campaign that we do, every single planning for resources that we do. It's a must. Rural has to be within the most important things that policymakers pay attention to when they design these policies. When they put money towards executing these policies, they should take into consideration the need of the rural areas and not look at it separate from what they do for urban areas. Thank you.
Great. Thank you so much. Now, Dr. Ahmed.
Maybe my first take-home message is keep doing the same conference every year. Inshallah, we'll keep attending the same. We are waiting for the recommendations from the conference. Regarding the topic, I think we have to consider listening to population more than sending them messages. We have to listen to their concerns. This is the advantage of doing on-ground awareness or initiatives for specific segment or area. We have to listen, engage the local leaders, and try to do impact measurement after, because the struggles for mass communication is that we don't know, did we change behavior or no, the feedback. So listen, engage, try to build a strong message and do impact measurement.
Excellent, thank you so much. Now back to you, Dr. Bhaisi, from occupational health and safety expert. From this point of view, is there a message that you want to tell the policy makers and health advocate or the audience about the rural health effect of the occupational health safety regulations, like a take-home message?
Okay, if I understand the question, you're asking about the rural health effect on the occupational health. It's like, it's not the...
No, my question is there a take-home message that, as an expert in your field, you want to tell the policy makers from your point of view?
Okay. Take-home message, sorry about, because the sound was a bit too much for me. From occupational health, I think the era of occupational, well-integrated national occupational health just started. There is very strong commitment from policymaker to create the right policy, to have the manpower to manage and to enable it. So definitely occupational health and safety will support rural health, because I mentioned it is fundamental part of occupational health. Most of our jobs or high-risk jobs is not in the city. They are mostly in the periphery, mostly outside. So this will add definitely value.
Definitely. Thank you so much. I don't know if the time allows me to have one or two comments or questions from the audience. Please, people with the mics, if you can, any comments or questions? Okay, I think Dr. Hatem is saying time's up. Thank you so much, everyone, for your listening. And I really appreciate our guest panelists for this rich, insightful comments. Thank you so much.
سيتم تكريم المتحدثين بعد قليل. نيابة عن معالي وزير الصحة سيقوم الدكتور عبد الله العسيري بتكريم المتحدثين في المؤتمر. On behalf of His Excellency, the Minister of Health, Dr. Abdullah Al-Asiri will honor speakers of the conference. المهندس ماجد فويز. Dr. Alan Bruce Charter. Dr. Wajid Ahmed. Dr. Saad Al-Battal. دكتور حاتم القحطاني. دكتور عبد المجيد شويعر. دكتور مروان بحيصي. دكتور خالد الحركان. دكتور فرح شروف. دكتور رندا مبروك. دكتور أنس شهيب. دكتور خالد العامر. دكتور أحمد بحمدان. دكتور صالح القحطاني. دكتور محمد الجعفر. دكتور صلاح السلمي. دكتور غازي الظفيري. أستاذ راشد الصوير. فهد الحجاج. ماجد السيحاني. نواف البندر. عبد الرحمن المطيري. عبد الله الحمدان. وأخيراً دكتور وادي العنزي. أيها الحضور الكرام، حان الآن الوقت عن الإعلان عن الفائزين في مسابقة ريفاثون التابعة لمؤتمر حفر الباطن الدولي للصحة الريفية. في البداية بالمركز الثالث، والفائز بالمركز الثالث هو فريق آي جيرني من تجمع مكة المكرمة. المركز الثالث فريق آي جيرني من تجمع مكة المكرمة. ثم ننتقل للمركز الثاني، والفائز بالمركز الثاني هو فريق أوج من جامعة حفر الباطن. والآن نصل إلى اللحظة المنتظرة، حيث نعلن عن الفائز بالمركز الأول في مسابقة ريفاثون. المركز الأول فريق ترياق جامعة حفر الباطن. ألف مبروك فريق ترياق جامعة حفر الباطن. Ladies and gentlemen, this concludes the morning segment. We will have a break for prayer and lunch. We look forward to welcome you back again in the afternoon session at 1 p.m. Thank you so much.
I see. Okay, so now I'm just. Yes. Here. Yeah, so just go from here. Click. I'm just testing. Oh,
الحضور الكرام، سنقوم بإكمال البرنامج العلمي في الساعة 1:15. شكرا لكم.
Testing. Oh. Hello? Yeah, this is better. This.
Huh? Then, when you turn it off,
Yes. Okay, I think it's fine.
Now it's what? Listen?
Now turn it off.
thank you. Welcome back. We now begin the afternoon program, focusing on learning from global and regional experience that can inform rural health strategies. Our next speaker, Dr. Farah Shroff, adjunct professor at the Department of Family Practice at the University of British Columbia, board member of Harvard Lab, an expert at Harvard Innovation Lab. Dr. Shroff is known globally for her work in One Health approaches. She will discuss how traditional ecological knowledge can be revitalized through contemporary One Health practice to improve rural health. Please welcome Dr. Farah Shroff.
Hello, everybody. Can you hear me? Hello. Welcome. I am Dr. Farah Shroff, and I'm here to talk to you about the concept of One Health. The title of my talk is Interdependence to Action, Revitalizing Traditional Ecological Knowledge Through Contemporary One Health Practices. A warm greeting to all the esteemed guests. It was lovely to see the Prince and so many dignitaries here, and all of you are truly dignitaries. So as you just heard, I am Dr. Farah Shroff. I founded a global nonprofit organization called Health Together, and I have been at Harvard as a Takami Fellow, and I continue to do a lot of work at Harvard. I'm also a faculty member at the University of British Columbia. I also teach yoga and dance and many mind-body activities. In this short time that we have together, I'm hoping to talk a little bit about what is One Health and how One Health can make a difference here in Saudi Arabia. So this is our agenda, a much bigger agenda than we have time for But I want to give you some examples of One Health, tell you about agreements that the world has made about One Health, talk about ancestral knowledge, the interdependence of our survival, and how here in this region there has already been successful implementation of One Health with the MERS pandemic, and just talk a little bit about One Health implications for healthcare systems, and then the collaborations I'm hoping to do with you. Okay, so can I ask here, does anybody know what One Health is? Hands up. Has anybody heard of One Health? Okay, sounds like we've got a nice raw audience. So One Health is an integrated approach that aims to sustainably balance and optimize the health of humans, animals, and ecosystems. It's a really interdisciplinary field. So the kinds of people who are here at this conference are perfect to do One Health. We need people who work in the health sector, engineers, dentists, veterinarians. We need almost everybody to implement One Health well. So here they are, farmers, agricultural workers, botanists. So many different professionals are required to do One Health well. You probably all know the concept of One Health very, very well. If you think about just bees alone, the pollinators of the world, there are many others, birds and butterflies, but just bees alone, they show you how we as a species are interdependent with other species. So we know that bees are integral for plant health, for ecosystems and biodiversity.
How to plan, to organize, and follow up the project and see its accountability. It gives us a roadmap. The project management actually gives us a roadmap towards defining what we do and why we do it, and this gives us the clarity. At the same time, it gives us a direction from the problem to the solution and guide us towards whether the road we are going through is accountable or not. Is it successful? Is it being measured or not being measured? So that's why the project management is an important issue in this aspect. So the theory of change is considered to be one of the theories that some countries usually, or some firms usually follow for the completion of the projects. And this is the theory of change, which depends upon 6 steps. The first step is the situation analysis and finding what is the problem, and also analyzing the problem, going through the literature, finding what other people do, and this is the first step. The second step is defining who are we going to act on, and what is the scope of the problem. We have to start small, for focusing on a small group, for example, and not going out of the scope to make sure that our project would be successful. And the third thing is the action, and this action includes the intervention to gain the outchain or the outcomes, whether these are short, intermediate, and long-term impact or outcomes. Framework 2 is the outcome chain, and the outcome chain, of course, we all understand about the Kirkpatrick 4 levels. We provide the project-based training for the group or the focus group we are working with, and then we will see what is the result together with the knowledge. Are they gaining the knowledge we have delivered or not? Are they gaining the skills, or is there an accountability for community health improvement of not? So this is simply the theory of change that should be applied before any project. Yes? So this is the strategic goal. We have to empower in the rural areas our rural workforce, the people who are working with us, the people who the community know. So it's very important to reach or raise the quality, the equity, and the accessibility of the rural areas. The solution is transforming the trainee into agents of change. whether they are nurses, midwives, interns, healthcare professionals, changing them from active to proactive for the prevention of the diseases and for the better or the promotion of the health. So this is something as it is a recommended training program in which first of all we have to design the curriculum. We have to do mastering the logistics of engaging with the remote populations. We have to understand the psychology and behind the health-related decisions. And the timeline, for example, would be a short timeline as a pilot study or as a pilot issue. The community delivery will depend upon, for example, 6-session public workshops, reaching about 15 to 30 rural participants, with supplying them with accessible materials, and then we will focus on the health priorities. We will find the gap and focus on the health priorities, including, for example, the nutrition, the maternal health, the preventive care strategies, and we will lead by newly trained healthcare workers putting their education skills into immediate practice. So we are, in this case, bridging the gap between the clinical knowledge and the community action through direct, culturally adapted engagement. For example, these are the task force in which the primary trainers will be the lead facilitators, and they will work with the primary trainees who would be those of the rural areas, including the nurses, the midwives, the maternal health workers, medical residents, community health workers, and then they will go into the secondary beneficiaries who are the health advocates and the community members. And this is a nice image showing how the trainer of the trainer has a multiplier effect as well. So the quality training equips professionals with evidence-based skills of safe, effective care measured by outcomes. So we have to measure the outcomes. In this case, there is a model for success that is led by nurse-led diabetic care, where they are trained on monitoring and testing the routine, for example, glycated hemoglobin, educating and counseling the patients, and managing and preventing, adjusting the doses, performing the food exams for the diabetic patients. And in this case, there would be a reduction. Actually, it's a project that has been done in our rural areas in Egypt. There was an outcome of reduction of in the rural areas of 0.5 to 1.5% of the glycated hemoglobins over an area of 6 months. And also about 60 to 70% of patients helping in the self-management. And of course, which is very important in the rural areas, that they were able to manage the patients in the rural areas, and there will be drop in the hospital admissions. So it's very important here. Another example of the equity is the midwife-led nutrition training for the Bedouinian families, where the program is designed for the using of the translated material into Arabic, also local foods and flexible schedules. And of course, for the pregnant ladies, the maternal health was promoted, babies were born healthier, and there was more community trust and engagement to strengthen programs. Now this is the bridging of the distance and the healthcare accessibilities. As has been mentioned before, the virtual clinics, the digital training, the mobile health on the move, empowering the community health workers with these facilities, and making sure that they understand what are the goals and the focus of this condition is important as well. So this is a small printout for the blueprint for the equitable healthcare training, in which we train the healthcare, for example, the interns, the midwives, or the healthcare professionals, customize them for the equity between the rural areas and the urban areas, and then deliver the accessible care, and then measure the outcomes and decide whether they are short outcomes and aiming for the long-term outcomes. Okay. Okay, thank you very much. This is the ASU Minafrai Leading Health Education, and we are very happy to collaborate. Thank you very much.
Our next speaker, Dr. Anas Shihab, Deputy Director General for Medical Affairs, Thoracic Surgeon at Security Forces Hospital, Riyadh. Dr. Shihab combines clinical expertise with leadership in healthcare intervention. He will present smart and innovative solutions for rural prevention, including mobile oncology care, wearable technology, and targeted to screening model. Please welcome Dr. Anas Shihab.
Is it on? Assalamu alaikum. بسم الله والصلاة والسلام على رسول الله. سعد الله مساكم جميعا. أحب في البداية أشكر اللجنة العلمية واللجنة المنظمة على الدعوة الكريمة. سعيد بالتواجد معكم والمشاركة معكم. Today I'm going to talk about few experiences that we've done in the medical services in the Ministry of Interior in the past few months. This is my agenda for today. I'm going to talk about a targeted screening model, then use of smart wearable devices. Then at the end I'll talk about the mobile oncology clinic that is starting over there outside. Our country is huge, is big, it's diverse, and to reach the community needed, it takes long distances, a lot of cost, and to provide a good medical care needs an innovation. So I'm starting with the targeted screening model. In Ministry of Interior, we have different sectors in the military employee, serving in the borders and serving in rural areas and environmental securities. So these specific targeted population were reached, and one of the examples that we've done is reach out in the Neom area and Tabuk, where these specific group of people that been gathered together and been giving a preventive measures in their health care. They were provided lifestyle modification and occupational health programs. So a group of expert physicians and healthcare providers traveled to Tabuk and Neom equipped with these medical devices, that is portable medical devices. They measured specific healthcare measures, also body composition parameters, body fat percentage, muscle mass, and visceral fat, and so on. Wide variety of blood work has been withdrawn from these employees, specifically CBC, fasting lipid profile, LFTs, thyroid function, hemoglobin A1C, along with history and complete physical examination. They were assessed with screening tools for this physical activity, for their sleep patterns, and so on. This is just a quick example of how these employees were approached in terms of their present complaint, chronic diseases, and what their vital signs are. And this is a sleep assessment tool where they've been asked about the snoring, if they feel tired, if they feel obstructed sleep or not, if they have any being treated for blood pressure or not in the past. And also their body mass index were gathered, their age, their neck circumference, and their gender, of course. They were provided eventually with the recommended dietary advices, including vegetables, fruits, water, whole grains, and healthy proteins. The data that were gathered is, as you see, 629 of these employees were screened. These percentages shows only the different sectors in the military services. Down is the diagnosed new condition that they have, which is depicted here. So 3 of them, they were have diabetes, but 4 of them, they were have newly diagnosed. They were not having diabetes before. And these are young population, military personnel in the field. They have diabetes, they didn't know about it, and they were diagnosed by reaching out preventive measures. They have 52 pre-diabetic, some of them hypertensive, but as you can see, the hyperlipidemia part is extremely high. 17% of them, they were having hyperlipidemia, which they never had known before, and they started treatment. Current smoker and quit smoking before, and they were inadequate health nutrition. 29% of them where they were reached by medical advices. The second agenda that I wanted to talk about today is the wearable devices, where a new innovation that comes in the different models. Sometimes you have watches, bracelets, rings, patches, and different technologies that these devices can be used to monitor people remotely. It can measure different vital signs, and it sends all these data to a specific command centers. This has been used in last year during the Hajj season, where these employees were put a bracelet and their vital signs is being monitored. And all these data were sent to specific command center. And whenever need to be intervened, a medical team will be alerted. It gives a heat map and a design where these people are located geographically, so it will be easier for the medical teams to reach. It measures the different vital signs, and then it gives the people in the command center a good view of the current situation of these people in the field. So an immediate intervention is taken whenever it is necessary. Also, these wearable devices, a bracelet, were tested in the southern region in Asir, where a group of military population also were being monitored remotely. And whenever an intervention is needed, this data is gathered into a command center and intervention is taken accordingly. The third talk I wanted to talk about today is the mobile oncology clinic. I encourage everyone to have a look at the mobile oncology clinic over there. It provides medical care and oncology treatments to people outreach, so it can travel to different areas and different regions to give full oncology treatment. It has fully equipped. It has a point of care lab where you can test specific, simple lab investigation before giving any chemotherapy agent. It has 2 hoods for chemotherapy preparation. So you can either give a pre-prepared chemotherapy or you can prepare chemotherapy inside the mobile oncology service. It has 4 chairs and it has different monitoring tools. It can provide virtual consultation to your patients with the specialist remotely, and 86% of patients reported easier access compared to hospital treatments. It's eliminated long-distance travels, reduces the stress with the travel times, and allows patients to incorporate the treatment during their daily activities, so that they need to travel long distances for treatment. 66% of patients have saving in cost, and they decrease burden in chemotherapy and the daily support they need, and reduces travel time, as we said. And thank you very much.
Ladies and gentlemen, please note it that the workshop will start for strategic planning will start at 2:30. Now, for our next speaker, we are now welcoming Dr. Khalid Al-Amir, Assistant Professor of Pharmacy Practice at the College of Clinical Pharmacy at Imam Abdurrahman bin Faisal, Saudi Arabia. Dr. Al-Amir has a strong experience in clinical research and trial design. He will discuss expanding access to clinical research and clinical trials in rural community throughout decentralized models and remote framework. Please welcome Dr. Khalid Al-Amir.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. أشكر اللجنة العلمية واللجنة التنظيمية في التجمع الصحي لحفر الباطن على الدعوة الكريمة وعلى التنظيم الأكثر من رائع. My name is Khalid Al-Amir. I'm a pharmacist by training. I serve as a Vice Dean of Research and Innovation of the School of Pharmacy at Imam Abdurrahman bin Faisal University in Khobar. I'm the current Director of Clinical Trial Unit. Following my PhD training in pharmacist-led randomized clinical trials, I've been working in multiple R01 funded clinical trials from the National Institute of Aging, which is a branch of the National Institute of Health in the US. We had a lot of experience with our clinical trial team before COVID and after COVID, which led us to the title of our talk today when it's come to decentralized clinical trial, remote data collection, and remote assistantship field work. In the last year, you saw and noticed the surge in number of clinical trials conducted in the Kingdom of Saudi Arabia. After the establishment of the Saudi NIH, also after the initiation of other funding entity like Radaya, other governmental funding prices that was offered to conduct clinical trial. It became mandated how we can involve urban and rural cities in that momentum in improving the clinical trial ecosystem in the Kingdom of Saudi Arabia. This is not a privilege how we can implement clinical trial through decentralized approaches to rural area like Hafr al-Batin and other rural cities in the kingdom, but how we can decrease the burden on the behalf of mega clinical trial centers in the Kingdom of Saudi Arabia, and to be more specific, in Riyadh, Jeddah, and Dammam. So we could start our talk with a brief question. What are trials with decentralized feature? So the norm that we have regarding conducting clinical trial is that the patient will come to the clinical trial site or the hospital for screening, seeking eligibility for their recruitment, randomization, allocation, then receiving the intervention. Then they will frequently following up for various variable collection in a frequent, subdivided, definite time. This will increase a huge burden on the behalf of clinical trial sites and healthcare provider, because it will disturb the norm of flow of clinical trial or clinical settings that the hospital is carrying. So decentralized clinical trials where some or all trial-related activity is taking place at the participant home or at a local nearby healthcare facility. With decentralized clinical trial, I can initiate an oncology clinical trial at Kmark or at our center at Imam Abdurrahman bin Faisal University, and I can recruit patients from Hafr al-Batin, from Hail, from Ar'ar, from Al-Baha, from those rural cities where we don't have access to well-established clinical trial settings. You have the option of creating a whole protocol consist of decentralized activity, or you can choose when you are building your protocol which activity will be qualified as decentralized. From feasibility assessment to seeking eligibility for recruitment, randomization, allocation, giving the intervention, collecting variables if it's lab variables, dispensing investigational medication product from local pharmacy, imaging services if you are using a radiology, and etc. So it can reduce the burden on two perspectives. It will reduce the burden on the mega center who's conducting the clinical trial, and it will reduce the burden on the patient from the patient perspective. So you don't have to pay the patient to come to you from Hafr al-Batin or from different rural cities to Riyadh or to Jeddah or to Dammam to have a follow-up visit, for example. So you could hear different words that we use interchangeably. We could use decentralized clinical trial, virtual assessment, or remote data collection. All of that synonyms, all bores in one definition, which is decentralized clinical trial. As you know, the average cost of clinical trial, even if it's a sponsor-initiated clinical trial, range from 1 million to 3 million Saudi riyal. They carry a huge burden on the patient, on the physician, on the clinical trial team, plus high cost. Failure rate, when we mean by failure rate, when we are screening potential participant for recruitment. Each clinical trial protocol will have an inclusion and exclusion criteria. So if I'm restricting my patient population or the pool of patients that I will be recruiting from only from my center in Riyadh or Khobar, I will have limited participant or potential participant to recruit in my study. But if I have some decentralized feature in my protocol, the whole country will be open for recruitment in my clinical trial. Decentralized clinical trial, the concept has been well established for more than a decade, but it gained a lot of attention during COVID-19 pandemic. During COVID-19, one of our RO1 clinical trial, it meant to be delivered in person. But the NIH and the US FDA, they released a statement to suspend all human data collection activity. So either you are risking to lose the fund allocated to you by the NIH, or you have to switch from in-person modality to decentralized modality. And this is what we've done with our reducing the risk of dementia through de-prescribing, which is a pharmacist-led intervention clinical trial. And we were able to recruit even more patients than the location that was supposed that we will recruit from. So recruitment rate, it will be optimized. So because you are having an increased pool of participants you can recruit from, you will reduce the burden for your patient as you are utilizing digital health tool and tele and video conferencing tool to conduct your follow-up visits. As well as expert site will gain more experience in using clinical trial management system, electronic data capture system, and the use of digital health tool, as Dr. Anas mentioned in the previous talk. So, decentralized clinical trial, it wasn't a result or a workaround when COVID hit us. It's been established and regulated by big regulator entity worldwide. From the MHRA in the UK, EMA in Europe, US FDA, and even the Saudi FDA, as you can see, they release a document to support management of clinical trial, especially data collection and conduct during COVID-19. And this is the basic or fundamental document that now we are working on to make it permanent. So why do we decentralize our clinical trial? We will include more patients, meaning we will have a more diverse population within our sample size. Also to keep the business momentum within our clinical trial, reducing the cost of delivering your intervention to your participant. Also, through the use of clinical trial management system, you are standardizing the way of collecting data through your electronic case report form, ensuring the highest data quality produced from your clinical trial. So you have your decentralized clinical trial toolkit. You can use all of them or some of them based on the protocol, based on the nature of the clinical trial you want to conduct. Moving from electronic consent, which we are working with the Saudi FDA to make it available for clinical trial team here in the country, video visit, telemedicine, home visit, digital endpoint, like collecting data from wearable device and digital health tool. Why it's very important to apply decentralized clinical trial in rural healthcare system like Hafr al-Batin? It will improve diversity and retention because you are taking into consideration patient-centric factor. So social determinant of health for your special population, including rural health patient, will be considered in the design of your clinical trial. Local provider integration. We know 100% for sure that rural healthcare system, they have the highest quality of provider, from physician to pharmacist to nurses. And this is a very good opportunity for them to be included in that clinical trial, momentum boosting the clinical trial ecosystem in the country. And one addition important factor is the implementation of technology-enabled care, where decentralized will become beneficial for any protocol if we are talking about a low or moderate complex protocol. So it can't be done with high-risk disease or an advanced clinical trial protocol. It's suitable for oral medication. If the adverse event expected from that intervention is minimal, it's a very good fit for rare cancer and rare disease. Since you are expanding the pool of potential participants, you will be recruiting. And your primary and secondary endpoint should be collected remotely. The Decentralized Trial and Research Alliance, they are a group of academic institutions, sponsors from farm industry, regulator entity, and even consulting firms. They came together under the DTRA organization to provide tools and materials to support the conduct of decentralized clinical trial. Here is the TubeStab map. This is decentralized clinical trial, which can mimic the actual clinical trial, the traditional clinical trial, from point A to point Z. So from developing your protocol, assessing the feasibility, your contract negotiation, your budget negotiation with your site qualification visits, your site initiation visits, your site activation visits, feasibility, randomization, screening, monitoring, up to the last patient in and last patient out, then inspection and audit after fulfilling your clinical trial requirement. Think about it as a metro map. Each station represents a clinical trial activity where each line represents a clinical trial segment. So one of the decentralized clinical trials that we finished recruiting last year is the Brain Safe clinical trial that we got an R01 funded from the National Institute of Aging. We developed a consumer-facing technology app for older adults to reduce the exposure to anticholinergic medication under the hypothesis that anticholinergic medication may lead to decline in cognitive function and dementia. We were able to provide each of our participants with a mobile device, and from the use of that mobile device, all the data will be poured into our electronic data capture system, which is RedCap, and here is the screenshot of our mobile app. So one of the most important key takeaway, it's a low-hanging fruit opportunity to decentralize clinical trial, but given the kingdom context, we should move with caution to decide which protocol fit a decentralized clinical trial mold. Thank you so much.
دقيقة بس خلنا أقدمك دكتور بس. Our next speaker, Dr. Ahmed Bahamdan, Assistant Professor of Family of Medicine at Imam Abdul Rahman bin Faisal University. Dr. Bahamdan has a first-hand experience working across different rural health systems. He will share his professional journey from Saudi Arabia to rural Australia, highlighting lessons learned from rural practice. Please welcome Dr. Ahmed Bahamdan.
بسم الله والحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. It's a privilege to be here. I would like to start by thanking the organizing and scientific committee for their invitation and everyone who made this amazing event possible. I'm Ahmed Bahamdan, Assistant Professor of Family Medicine at Imam Abdul Rahman bin Faisal University, Obesity and Family Medicine Consultant. So my talk is about my journey as an overseas doctor in Australia, not because it's unique, but because it reflects how the system works and how it may offer insight for leaders and policymakers. Through this experience, I will share how training pathways, supervision, and workforce policies shape care delivery in rural communities, and finally, some initiatives designed to support doctors and communities. So it all started when I was accepted in a training position at a fellowship in obesity medicine at Royal Prince Alfred Hospital, one of the well-known hospitals in Australia. One day, during a routine clinic, I saw a patient who had unremarkable clinical history. What was remarkable was his journey to the clinic. So he mentioned driving for 6 hours to attend an appointment focused on weight management. 6 hours, not for surgery, not for chemotherapy, but for an advice which can reasonably be given in primary care. Another patient arrived with her daughter who had special needs, traveled more than 12 hours by train to reach us. At this point, the question was unavoidable. Why were people bypassing local services and traveling long distances for care that should exist close to home? The answer was not complexity alone. One of the key factors was trust. When patients lose trust in the system closest to them, they are more likely to travel long distances in search of care. So let's see the system through the eyes of those who work in it. In Australia, the journey to becoming a general practitioner or a family physician is not a single road, but different pathways designed to accommodate different needs and situations. The main bodies to train family physician or GPs are Royal Australian College of General Practitioners and the Australian College of Rural and Remote Medicine. This is basically for Australians and New Zealand graduates. For overseas doctors like me, the options are limited. So mainly we have the RACGP. After you get the fellowship, you get to train as a rural generalist. So you basically apply to the college, which does some assessments based on your clinical experience, based on your training. They assign a supervision level through the board of through the medical board framework of supervision. So the goal of this supervision is to move you from limited provisional registration to fellowship or complete specialist recognition. The core principle is a safety first, where supervision intensity decreases as competency increases. Locations are mostly according to M 2 to 7, which I'll come in the following slides. So imagine someone just coming to a new country where there's a new system. This is a very useful strategy in helping doctors just starting to work in rural medicine. So level 1 supervision is a direct supervision where you see each patient along with your supervisor. Level 2, most of the time, the doctor sees your patients. Level 3 is a distant or remote supported supervision. Level 4 is only periodic audits. So you're not alone. You have a team that supports you. The team is, as we said, the supervisor, the medical educator, who is an RCGP employed doctor who performs meetings, work-based assessments to ensure safe practice and you are included in the system. The program or administrative staff who helps start you in the program and initiate a provider number. In Australia, each doctor can have multiple provider number. So at each practice you work in, you need a designated provider number to that practice. So these people help you. I will not go into details about the duties of a rural generalist. Dr. Saad Al-Battal mentioned this in details, but generally, a rural generalist is not a doctor based in clinic alone. He can work as an emergency doctor, visiting aged care and his clinic. You sometimes work in a town just by yourself, there's no other doctor. So if you are willing to provide after-hour services, it's there. You engage in public health roles, so you advocate for your population and policymakers and decision makers. You engage in procedure, emergency, and higher complex cases. So briefly about the Australian system, it's a mixture of private and public system, mainly funded by the government, and the core funding mechanism is Medicare. So what is Medicare? Medicare is the Australian's national public health insurance scheme funded by the government and provides access to subsidized services, mainly GP consultations, in-hospital services, tests and blood and investigations, and specialist consultations out of hospital. So this is a very interesting idea. It's called M Modified Monash Model. It's a system, it's an Australian standard system for classifying geographic locations, combines population size and remoteness, and it's primarily used by the Australian government to guide health workforce distribution and funding. The reason why I'm bringing this is that each or every overseas doctor who is not trained in Australia has to work in an area which is not M1. So M1 are major cities, 2 regional centers, 3, 4, 5, etc., large, medium, smaller rurals, according to the location and the population size. So the idea is this model helps funding and service planning, allocation of aged care funding, national disability scheme. Usually higher M categories attract more funding and more support. For workforce retention and migration reasons, M3 and 7 usually have faster or offer faster visa processing, priority pathways, and additional incentives, which we will be talking about later. So this is the Southern Highlands. This is where I work. A very peaceful place. It's considered a retirement area. So I see most of the elderly population there. And one of the perks of working in a small town is that you get a sense of community. And you get the chance to be part of this community. So you go to the supermarket, you see one of the patients. You go to the barber shop, you see one of the patients. You go to fix your car, and you see one of your patients. And if you're lucky, sometimes you get discounts, which is great. And so it's an elderly population. I see one family where I get to help 4 generations. So I treat the grandmother, I treat the mother, I treat the daughter, and the granddaughter. So imagine 4 generations, 92 years old, and the smallest was just born 2 years old. So this is one of the famous lakes there, and you can enjoy the different colors of different seasons. And subhanAllah, this is a lake on top of a mountain. Amazing. So back to our main topic. So this is also one of the controversial topics. A nightmare for some doctors, yet a lifeline hope for rural communities. So basically, it's a policy known as Section 19AB. It requires any doctor who is not a New Zealand or Australian graduate to work at priority areas for 10 years. So you cannot work in Sydney, you cannot work in Melbourne, the big cities, unless you serve for at least 10 years to those areas. The purpose, obviously, ensures equitable healthcare access across Australia. So the 10-year period cannot be waived, but it can be shortened. So the more remote area you work in, the more scaling credits you get, meaning this 10-year rule can be reduced to 9, can be reduced to 7 or 5. If you serve further and more, you get to reduce that year, 10-year rule. So I'll be talking about some of the government initiatives that I find very useful in terms of health force retention. So there are financial incentives for people working in rural areas. Basically, it provides financial support directly to doctors to practice in regional, rural, and remote communities. Payments are scaled based on remoteness and length of service. So again, the more you serve, the further you serve, the more income you have at the end of the year. The Health Workforce Scholarship Program provides bursaries and support in terms of courses, conferences. So for example, you notice that your community has some diseases that require some skills, and you don't want to keep sending patients to the closest hospitals, which could be hours away. You decide to learn these skills to help your community. You apply for this scholarship program. You give them your reasons, and when they accept it, you get to go to that conference or course, and even accommodation and travel is supported. So training and career pathways, I'm not going to be talking about this in details. We can discuss this further at the workshop, but rural doctors or doctors who work in rural areas get some support in getting their fellowship and training, so they get more opportunities in underserved areas. Structural and recruitment, we talked about the scholarships. It's done under rural workforce agencies. Each state in Australia has a rural workforce agency. They support doctors in terms of conferences and courses. They also offer locum opportunities for rural areas. Primary health networks, which is similar to clusters in Saudi Arabia, تجمعات صحية. There are 31 independent regionally based clusters around Australia. So telehealth support for doctors, I find these very helpful as a doctor working in an isolated a rural far area. They are initiatives by some of the bodies. Telederm, for example, is an initiative by Akram, one of the colleges of rural medicine. Basically, you are in a rural area, you see a skin lesion, you cannot send each skin lesion to hospitals and doctors that are away. And another thing for safety, you're not sure if this lesion is malignant, can it wait, do I have to send it urgently? So the idea of this initiative is you take consent from the patient, you take a picture of the lesion, you send it to those specialists, and within 48 hours, they reply with their suggestion or a plan. Again, allergy assessed, similar idea. You send your consultation to them, to the same college, and they reply back to you. Telehealth and virtual care is very much supported. The patient needs to do one visit per year, and the rest of it can be done through virtual care and telehealth. One of the support that you get in further or remote areas, some of the emergency support by nonprofit organizations such as CareFlight, Royal Flying Doctors, some of the regions where the ambulance cannot reach to those communities, airplanes or helicopters can go there and help in case of emergency. So working as a rural generalist sometimes could be scary. It is challenging, but at the same time, it's fulfilling. It gives you a sense of achievement, very rewarding experience. You feel isolated, yet you are connected. Each patient you send to a specialist or allied health, by law, they must reply to you with either the plan, what they have done. So you get a sense of support even though you are far. You are a leader of a team with multidisciplinary team. The main focus is you. As I said, sometimes you're the only doctor in the town, and imagine the stress you get. And finally, you get the chance to be part of that community, which is very fulfilling. Thank you.
Ladies and gentlemen, this concludes the current session of our scientific program. Now we will take a coffee break for 5 minutes. Please note that strategic workshop will start at room 1 and 2 at 2:30. Please note that our program will continue at 2:35. We're looking forward to see you again. Ladies and gentlemen, welcome back and thank you for joining us on time. We will now resume the scientific program with our next session, which focuses on particular lessons from real-world rural health practice. Our next speaker, Dr. Saleh Al-Qahtani, Assistant Professor of Pediatric at the College of Medicine and Director of Research Planning and Performance Indicator Monitoring Unit at Imam Abdul Rahman bin Faisal University. He will highlight the importance of well-child visit as a cornerstone prevention care in rural setting. Please welcome Dr. Saleh Al-Qahtani.
Assalamu alaikum, good afternoon everyone. In my talk today, I'm trying to build the case that the most important preventative service that we can provide for rural children is a perfectly done well-child check that fits the rural setting. So I'm going to describe what we mean by well-child check and explain why rural children are at a higher risk and apply practical strategy to try to overcome them. So rural children, from research, we know that they are at higher risk or they're less likely to receive preventative care compared to urban children. And when we factor in family income, we see that all the way, at all brackets, they're still behind. Looking at childhood adverse event, which is defined as childhood stress or event that is associated with long-term health poor outcome, such as death of parents, divorce, we see they are more likely to have adverse event, and 7 out of 9 are lower or higher compared to urban children. They are at a high risk for obesity and food insecurity also. So let me go through 3 real cases for rural children that I have encountered before. The first one is a 3-year-old boy who came with the mother because of a concern about autism. He's not responding when she called him and he's not talking. He missed all of the visits after 12 months of age due to lack of transportation. And on physical exam, he has bilateral otitis media with ear effusions. He was referred to ENT for ear tubes, and he received speech therapy. Second case is 15-month-old girl who's walking funny. That's the main complaint. Mother is anti-vax because the older sibling has autism, and she has this link of autism and vaccine. She was last seen at 6 months of age. She was a breech baby. Imaging confirmed developmental dysplasia of the hip. She was referred to orthopedics, but it was too late for casting, and she underwent hip surgery. The last case is a 12-year-old boy who looks younger and short. His father is an elementary school teacher, and he pointed that he looks younger than his age. On exam, he has bilateral undescended testes. And his father was compliant. He went for every vaccine on time, but nobody ever examined him. Unfortunately, he underwent orchiopexy. He has low testosterone, so he needs lifelong testosterone injections. He needs to be screened for testicular cancer, and he might be infertile. The sad reality here, all of these problems are what well-child check are designed to detect early when fix is easy and cheap. So let's define what we mean by well-child check. It's not only weight, height, shots, and goodbye. It has way more preventative value. So you'd assess growth, you'd assess development with validated questionnaire, you would do proper age-specific physical exam, you'll give all immunization needs, you give anticipatory guidance to the family, which is age-specific, you address social needs and overcome barriers. And most important, building trust, because rural communities run in trust. So every visit is another opportunity to have more trust and win the parents. Now we know what is will child check. When do we do it? And it's usually high frequency early on because of the rapid development of the brain and developmental milestones. And then it becomes annual. The most important anchor ages, which we have the most preventative values, are between 2 months and 30 months of age. Every missed visit is missed window for preventative care. There is an echo. Can we turn off this mic? So to make sure that you deliver every visit, you deliver the right guidance, you do the right things. You deliver the right thing, you need a framework just to make sure you don't miss anything. I looked and we have the child health passport. It's a parent health record of 90 pages. It's look a child from birth until 5 years of age. And it's a track growth and development, and it has some education. So it's a record. Another framework is the Bright Futures from the American Academy of Pediatrics. And it's scheduled based on clinical guidelines for prevention. It tells you what to do specifically at every visit in terms of prevention and screening tools and anticipatory guidance. It has more visits as highlighted here in red. It continues beyond 5 years annually until 21 years of age. We have very extensive immunization schedule, alhamdulillah, in Saudi Arabia. Just keep in mind, sometimes you need to bundle the care. Sometimes you can give vaccination earlier if that fits your patient or is going to help your patient to receive all the vaccines. I'll just cover an update for RSV, which is a nightmare for us as pediatricians because it's the most common cause for admission and it is responsible for 100,000 deaths per year. So now we have Breezvo, which is adult vaccine for RSV. We give it to the mother at week 32 to 36 of pregnancy. The child will have antibody through the placenta and it will protect him his first RSV season. But if the mother didn't receive the vaccine or her status is unknown or the vaccine was given less than 14 days before delivery, then you need something extra, which is nirsevimab. It's monoclonal antibody that if you give, it gives you protection for more than 5 months against RSV. And in this Melody trial, it's a landmark trial that show decreased admission risk by 80%. So if the child is born before the RSV season, before September, you wait until the season, or 2 weeks before the season, you give the vaccine. If the child is born during the season, between September to March, you give him immediately after birth. And this will give him protection for the first season. Moving to development, wait and see loses time. This is not good for your rural kids because they always present late. So you shouldn't waste opportunities. Surveillance is important, and there is a difference between surveillance and screening. Surveillance is when you ask or take developmental history. When you, during examination, check developmental milestones. When you ask the parents if they have any concern. But in screening, it's a validated tool that detects developmental delays. The tool that we use as pediatrician is called Ages and Stages Questionnaire 3. It's 30 item questions that's filled by the parent, and it tells you if there is any developmental delay between 6 months and 5.5 years. You have to do it at 9 months, 18 months, and 30 months. Moving to autism. When we say autism screening, we don't mean diagnosis. You need way longer time to diagnose. You have to normalize it for the family. I always tell them, this is routine. We do it for every child. I am not suspecting your child has autism. Earlier support is associated with better outcome for autistic kids. It's done at 18 and 24 months. We use the MCHAT, which is modified checklist for autism in toddlers. And it's 20 item yes-no questions. If it is positive, it has sensitivity of 83, specificity of 94. You have to do proper for evaluation by a psychiatrist. Moving to behavioral and social screening, just keep in mind in the first 6 months, if the mother shows signs of depression, if you have any concern, you have to do proper screening for postpartum depression. We have the strength and difficulty questionnaire. It's a wide-angle behavioral social screen that assesses hyperactivity, conduct, communication. We do it annually between 2 and 17 years of age. For children above 11 years of age, you have to do annual PAQ adolescent to assess for major depression. It's recommended once a year. For adolescents, it's better to ask about vaping, smoking, and substance abuse. Just to give counseling, it's better to do it without the parent being in the room. Moving to growth and nutrition, you have to track trend, not single point. So we look at the trajectory in general. For children below 2 years of age, you have to do head circumference every visit, and do not use BMI at all for below 2 years of age. You have to use weight for height. Always use Saudi growth chart, even if your EMR give you WHO or CDC. For nutrition, promote breastfeeding every visit during infancy and support the parents. Counsel them about nutritional milestones around introduction of solid foods. Vitamin D supplementation, especially for infants who are exclusively breastfed. Counsel about avoiding sugary drinks. Safety in rural setting, they have long commute, so it's recommended to counsel about car seat use and seat belts. Farm equipment, I still see cases of organophosphate poisoning, which is insecticide. Make sure everything is locked. Use helmet with ATV. Milk pasteurization to prevent brucellosis. If the family is using well and fluoride is low, it's recommended to supplement with oral fluoride between 6 months and 5 years of age. It's common in rural area to have tanks, water tanks or wells. Make sure there is barriers. And finally, for firearm safety, make sure the firearm is locked and unloaded. Moving to oral health, which is usually missed, it's easy fix. They are at high risk for dental caries, and they don't have good access to dental services. So you should phase out the bottle by 1 year of age and prevent drinking juice during the first year of age. It's recommended not to use any sweetened drinks until 3 years of age. Fluoride varnish, it takes 1 minute. The nurse can do it in the clinic and to protect the teeth between 3 months to 6 months. And brush with fluoride-containing toothpaste from the first tooth. Age-specific physical examination that's usually missed. You have to do full examination, but these things that sometimes are missed. For infant, red reflex to check for retinoblastoma up to 1 year of age. Hips examination, sacral dimples, and testis in male. You have to check annual blood pressure annually above 3 years of age, at least once a year. Vision and hearing screen annually above 4 years of age. And finally, scoliosis screen with Adam's test between 10 and 14 years of age. Screen time is important these days with the social media and internet. It's prohibited below 18 months of age, unless it's for video calling. Between 18 to 24 months of age, it's discouraged, but if family used to use it, they have to use high quality content, and the parent has to watch with the child. Between 2 and 5 years of age, less than 1 hour per day. There should be also co-watching with the parents. More than 6 years of age, there has to be consistent time, and you have to protect sleep. No TV for 1 hour before sleep, and no TV during meals. Any blood work recommended? If you have neonate, 2 minutes. If you have neonate with jaundice, beyond 2 to 3 weeks, you have to do fractionated. Fractionated bilirubin. At 9 years of age, 9 to 11, check for dyslipidemia and liver enzyme for fatty liver. There is no specific imaging recommended except for hip ultrasound for those at risk, breech baby, or who have family history of hip dysplasia. You do hip ultrasound at 6 weeks, regardless of physical examination. The others are needed only if the examination is abnormal. So why well visits does not work in rural setting? Here we see the map of Saudi Arabia. It shows the population density and we have 5 million people living in rural area. There is distance and travel burden. There is time of work that the parent has to take. Sometimes they bring all the children because nobody can take care of them. Workforce shortages in our primary health care and lack of training. All people get trained in big cities and they are not exposed to rural reality. Limited clinic hours, or there is high provider turnover because they leave to better jobs, and there is lack of trust due to this. So what we can do to overcome these challenges, first starting with the clinic, opt-out system. Every time you see the child, schedule the next appointment, call them before the next appointment for a reminder. Bundle care, if one child is coming, see all the other kids. If they come for acute visits, do preventative visits at the same time. Standing order, team-based workflow, and read a questionnaire to make the transition or the trip smooth. Build catch-up protocols, and provide point-of-care testing. What about solution outside the clinic wall? One of the very good examples are school-based clinics. It's the most established entity in rural communities, the school. Go there and meet the children, provide care there, because parent does not need to leave work. There is no transportation issue. And the children are there all the time. Mobile health units, bringing pediatrician or services to the communities. It has to be consistent schedule for people to know when you are coming and prepare for you. Outreach days, use trusted community members to educate and transport support. Telehealth, best for counseling, follow-up, and parenting coaching. Not substitute for vaccines and full examination. You can store videos, pictures, and establish systems to connect with subspecialists. Telepresenter using virtual stethoscope, cameras. You can use trusted establishment platform. This is Yanmo. It's connected to Tawakkalna. You can go and do developmental screen for your child. Why not for all screening tools that we have? Build hybrid pathway for subspecialty care. Also policy things you can do, mandatory rural rotation for all trainee. It's present in Canada and Australia, we have to do it here. Establish rural residency tracks, match-based employment to retain people, distinct rural specialty with extended scope of practice. So all these stories that we heard at the beginning can have different trajectory, and all the problem can be prevented early on if they had well child check. And take-home message, prevention is time sensitive. Rural barriers are real and solvable. Listen to your community and involve them in your solution. They're not the problem. And system beat willpower. If you make the best thing, the easiest thing to do, it will happen all the time. Thank you very much.
We are pleased to welcome Dr. Mohammed Abdallah Al-Ja'far, Assistant Professor for Neuropsychiatry and Psychosomatic Medicine and Forensic Psychiatry at King Saud University. He will share global experience in implementing WHO MH-GAP framework in rural healthcare. Please welcome Dr. Mohammed Al-Ja'far.
السلام عليكم ورحمة الله وبركاته. الصوت عالي؟ شكرا جزيلا. طيب صراحة سعيد جدا أني أكون معكم اليوم إن شاء الله بإذن الله سبحانه وتعالى. انها تكون حاجه خفيفه لطيفه. ما اوعد انا اسوأ واحد في تايم مانجمنت. Please accept my apology. I need to be bilingual today because some of our colleagues, psychologists and social workers, they are not a good friend with English. So I will use Arabic and English as much as I can together. Okay. I'm so glad to be here today. Thank you so much for the scientific committee, the organizing committee, and حفر الباطن cluster for this great event. Today I will, if you don't mind, please just prepare your mobile. جهزوا الجوالات حقتكم. I need your help in some slides to scan the QR code. if you don't mind. في بعض السلايدات بيكون فيها QR code أحتاج مساعدتكم فيها. Okay, أول واحد. Just scan it and answer it directly. Okay, it's not a promising result. That I need an extra 5 minutes or 10 minutes. Okay, there is a good news. Some percent 7%, 88. Still there is some, they are not sure. Okay. So, بداية we are talking about more than 80% they are not familiar with this program. This program actually is one of the WHO programs developed around 2008, I think so. But why we are talking about what we call it mental health gap? Why it's important, especially in the rural area? ليه يهمنا مرة في المناطق الريفية؟ الحقيقة إنه برنامج يضمننا because there is, unfortunately, there is some obstacle in these areas, including most of the people they are contacting primary care as a first help provider. يروحون أغلب الناس يروحوا برنامج الرعاية المنزلية. Unfortunately, there is a significant shortage of sub-specialized or specialized health worker. Sometimes they need long travel to take the consultation, and also there is big query about the continuity of care. استمرارية العلاج ومتابعة المريض قد تأخذ وقت طويل جدا بالذات في المناطق الطرفية أو المناطق الريفية. أوكي، فالبرنامج هذا صمم حتى يساعد في هذا الموضوع. So for task sharing combined to help with supervision and treating those people in need in those areas. Okay, why it's fit? ليه ممتاز؟ evidence based عليه أبحاث مرة كثيرة. adaptable أقدر أطبقه في أي نظام صحي and also تقدر تبدأ فيه على طول. و it's empower non-specialist providers. الناس اللي ما متخصصين نساعدهم بشكل مرة كثير، فبالتالي it safely assist, treat and refer priority mental, neurological and substance use conditions. واللي هذا هو المين aim of this program. الثلاث حالات والكونديشنز هذه بشكل عام هو اللي تساعد الناس أو البرنامج هذا يساعدهم في إنهم يوصلوا للمختص. Okay, why now? I think it's important to know that the global burden is large. في 2020 depression was the second leading cause of disability. كان ثاني أهم سبب للإعاقات على مستوى العالم في 2020. ولا زال للأسف النيد increasing والاحتياج يعني more than we expected. فاللي منكم يقرأ عن global burden of disease، لا زال mental disorder remain among the leading cause of health-related burden worldwide. Unfortunately, there is no evidence of a reduction. The other point, or the other point to think, it is one of the action planned during up to till the 2030, and it is implanted also in the mental health atlas tracking integration progress. Okay, what is it? As I mentioned, it is a program designed to fill the gap for the rural area to help health practitioner specifically with mental illnesses, neurological problem, and addiction and substance use disorders. في غالبا هو مصمم البرنامج للناس اللي يحتاجون استشارات او رعايه من ناحيه المنتل هيلث او من ناحيه المخ والاعصاب او من ناحيه استخدام المواد المحظوره او الادمان. زي ما ذكرت هو بدا في 2008 تقريبا. هذه بعض التولز اللي could be used. Maybe we'll discuss it later in separate workshop. وش الحالات اللي يشوفونها؟ Mainly they are seeing multiple cases including depression, psychosis, bipolar, epilepsy, seizure, and child and adolescent mental cases and behavior problem, dementia, and drug use disorder. هذه يمكن هذه أهم الحاجات اللي هم يطالعون فيها بلس اللي included مع الحاجات هذه كلها قضية السيفتي. How can we help our patient if they have safety problem? Okay. Usually this program is very important, or this initiative is very important because we can use it in multiple situations. We can use it by multiple organizations, either governmental or NGOs, أو حتى بعض المرات في academic centers. ولا حاليا there is more than 90 centers using this program. Okay, usually what is adaptation really means with this program? Training, training, training. Then after that we are talking about integrating primary health care centers services and delivery. وصمم تقريبا ليساعد الناس اللي في الرعاية الأولية إنهم overcome those problems. And بالتالي طريق إنه يسوي لنا national package تساعد الناس في البريفري ولا الرورال اريا. اوكي. نبهيني ترى انسى من الوقت. طيب. فبالتالي to implementation logic for this program, usually you start with plan and then that prepare ourselves first of all as a health practitioner and our colleagues in the primary health care center in the rural area. Then we'll go to implement this program there and monitor and improve the quality of those programs. فبالتالي احنا نحتاج مرة ان في البداية نسوي تحليل للواقع situation analysis، ثم بالتالي نسوي adaptation على السيستم اللي هو موجود فيه حاليا، ثم moving to capacity building and في الأخير نقدر نوصل خدمة نوعية تساعد الناس هذولا اللي صعب جدا توصل لهم الخدمة في المناطق الطرفية أو المناطق الريفية. أوكي. يمكن هذا this an example كيف ليه هو يشتغل على أو خلينا نقول very beneficial for primary health care centers. في الأخير يساعدني في short decision support، يساعدني في اتخاذ القرار، يساعدني في protect referral routes and also simple follow up. وبالتالي يساعد الناس انهم يحطون سكجول معين في السوبرفيجن والمتابعه والتدريب. من الحاجات اللي تسرع في المناطق النائيه والريفيه اهم حاجه التلي كونسلتيشن. والحمد لله يعني لما نتكلم عن السعوديه we have one of the biggest largest telemedicine hospital. والاستخدامه بالذات في هذا الاريا المنطقه حق التخصص في المنتل هيلث فرق معانا كبير في last 3 years. إضافة إلى shared care clinics أيضاً in person إن الواحد يحضر مختص يحضر في العيادة نفسها أو also we can use it virtually. Okay. This is as I mentioned the workflow usually by identifying the problem we need to solve it, assess it, acting on it, and doing the follow-up to reach the optimum solutions. Okay, during implementation of this program, it's important to know the rules. الناس وش المفروض يسوون. كل واحد في البرايمري هيلث كير سنترز ولا في المنطقة الريفية لازم يعرف الدور حقه عشان يسهل العملية. لما أتكلم عن التمريض، لما أتكلم عن الجنرال براكتيشنر ولا الفاميلي فيزيشن، لما اتكلم عن السايكولوجيست والسوشيال وركر والكونسلر، او حتى اتكلم عن دور السايكايترست اللي هو السب سبيشالايزد او سب سبيشالايزد سايكايترست. كل واحد من الناس هذول له دور معين في السيستم، اذا ما يعرفه ما راح يقدر يساعد فيه كثير. اوكي كم بقي لنا 5 دقائق يعطيك العافيه. اوكي طبعا تريننج هو الكورنر ستون اوف ذس بروجرام. اذا ما صار في تريننج كويس غالبا البرنامج هذا بيفقد خلينا نقول الفعاليه حقته بشكل مره كبير. الحاجات اللي تساعد في التريننج يمكن some examples التي او تي والورك شوب والستراكشر سوبرفيجن، لكن اهم شيء في السوبرفيجن والتريننج هو قضيه انه كيف انا اسويها مره واحده ما سويت ولا شيء، لكن لابد يكون عندي خطه لمتابعه هذا التدريب عشان اقدر اساعد الناس هذول سواء زملائي المتخصصين او العاملين في القطاع الصحي او لمساعده المرضى، سواء باني اسويها باجتماع اسبوعي او مرتين في الاسبوع، والاون ديماند كونسلتيشن والاوديت وقضيه الجوينت كلينيك والبير ليرنينج سيركلز. اوكي I mentioned telemedicine and the most important point about the telemedicine, so I can pass this area. Again, how can you use telemedicine to help ourselves with this program? Tele-supervision. أيضا قضية التلي-consultation في الكومبلكس كيسز بالذات، وأيضا في موضوع التريننج قد يساعد بشكل مرة كبير، والشيرد كير فيرتشوال كلينيك، وفي there is very important experiences في المستشفى الافتراضي مستشفى الصحة الافتراضي على موضوع الشيرد كير فيرتشوال كلينيك، انه يكون طبيب متخصص مثلا في الاطفال الطب النفسي للاطفال والمراهقين موجود في الرياض وقاعد يساعد زملاء رننج الكلينيك والسيرفس في حفر الباطن ولا في تبوك ولا في الحدود الشمالية ولا في جيزان ولا ايا كان. اوكي and finally the advice line. لا في جهود الان في وزاره الصحه باذن الله سبحانه وتعالى انه يكون في لاين خاص للهيلث براكتيشنر يساعدهم في الوصول للمتخصصين. اوكي زي ما ذكرت تريننج وانس انت معناته انك اعطيته مهاره بس حكمت عليها انها تموت. اذا ما كان في متابعه ما راح ينفع البرنامج هذا بشكل مره كبير. ايضا قضيه من العقبات والمشاكل الكبيره في البرامج هذه اذا ما كان عندي بلان كيف اتعامل مع الميديكيشن سواء الموجوده او غير المتوفره. وايضا اذا كان فيه فراغات او مشاكل في قضيه شلون اسوي ريفيرال، اذا ما اعرف ولا اعرف الديماند حقتي في بنفس الطريقه البرنامج هذا راح يفقد اهميته. اوكي طيب there is some examples. I will not go through all of these examples. اثيوبيا عندها تجربه مره ممتازه. يمكن one of the most important or striking thing in this experience انهم سووا دراسه لمتابعه الناس اللي عندهم بايبولر ولا سايكوسيس خلال 12 من 6 ل 12 شهر. وجدوا clearly there is feasibility and clinical improvement significantly with those patients. بالذات ان المناطق الريفيه او البريفريز في اثيوبيا مره كثير. الشيء المميز اللي احنا ممكن نستفيد منه من التجربه الاثيوبيه plan for supervision and referral from the day one. ما انتظروا الى نهايه البرنامج عشان يسوون تقييم او عمل هذه الخطوه. ايضا في تجربه جميله جدا في نيبال اهم شيء فيها ان كانت including the whole system من بدايه الوزاره الى المراكز الصحيه في البريفريز، وكان فيها كلير باثوي كلير من ناحيه الميجر اكروس الليفلز والتريننج وقضيه موضوع الاونجوينج سبورت. كان ايضا في تجربه باكستانيه وايضا تجربات تطوعيه اللي في الكوارث والازمات. الاردن كان لها تجربه مره ممتازه وكان في انيشيتيف صممت خصيصا للاردن، واعتقد انها اكزامبل مره ممكن نستفيد منه. يمكن اهم درس يهمنا في تجربه الاردن انه غالبا الهايلايت انتجريشن اوف منتل هيلث اند سبستنس يوز ديس اوردر في البرايمري كير سنترز، وكان واحده من الجود اكزامبل للريجنال اكسبيرينسز اللي موجوده. اوكي again this is the last thing. خلصنا صح؟ اوكي احتاج بس to help me with this question. What do you think انه the most important barriers to implement these programs? You can write whatever you want بالعربي بالانجليزي up to you. Execution, yes, totally agree. Anything else? لحالات اتفق تماما. مان باور extremely agree. Commitment, yes. طيب حفاظا على الوقت عشان ما زعل زميلتنا هناك، سمبلي يمكن ذكرتوا معظم الحاجات اللي انا ابغى اتكلم عنها. لا ننسى موضوع الكلتشر، الاستجما، الورك لود، وايضا المان باور اللي ذكرتوها، وقضيه الميديسن سبلاي. الميديسن سبلاي بالذات في الحالات اللي لها علاقه بالمنتل هيلث ما هي حاجه ايزي، لها سبيشال ريجوليشن، سبيشالي الكنترول ميديكيشن. كل هذه الجهود لازم تتضافر عشان نوصل لتجربه ثريه كامله. في عده جهود على مستوى الوزاره، يمكن هذه تو اكزامبلز على حاجه هيستوريكال، على قضيه كيف المحاولات القديمه في امبلنتنج الموديل هذا في السعوديه، وايضا في تجربه المنطقه الشرقيه في نشرت تقريبا في قبل يمكن 10 او 11 سنه في واحده من الامبورتنت جورنالز عن their experience integrating المنتل هيلث في البرايمري كير. في حاجات كثير يحتاج نتكلم عنها، بس مضطر اني اوقف هنا عشان ما انضرب. اوكي this is the last slide. اعتقد انه مهم جدا ان نعرف ان نحتاج كل الناس هذولا يسوي الشغل حقه doing their work to come out with significant important helping program for our people. Thank you so much for your time. السلام عليكم ورحمة الله وبركاته. الله يعطيك العافية. شكرا.
Our next speaker, Salah Al-Salami, Executive Advisor at Mecca Health Cluster Health Holding Company. He will discuss lessons learned from strengthening the performance of small rural hospital based on real-world experience. Please welcome Dr. Salah Al-Salami.
بس كيف السلام عليكم ورحمة الله وبركاته. سلايد. السلام عليكم ورحمة الله وبركاته. طبعا القيادات الأكاديمية التي سبقتني صراحة في العرض أتحفتنا صراحة بجميع البرامج الجميلة والتي المميزة نقدمها في الصحة الريفية. Our talking today about operational plan for hospital 50 beds. So the majority of hospital in peripheral area is 50 beds. So how hospital 50 beds in our kingdom, about MOH. Just imagine how much. 40%, 50%, 60% about our hospital. How many? 60%? 40%? Is more than 45% of our hospital is 50 beds. So, the majority of the beds on 5 cluster. 5 cluster and more of 20 cluster is half the majority of 50 beds hospital. So, our challenging is mainly in 5 or 5 at least 48% of hospital 50 beds in 5 clusters. The Taif cluster, Eastern cluster, Qasim cluster, Jazan clusters, and the Medina clusters, Hayat cluster is totally, this is our hospital, 50 beds hospital in this cluster with a lot of challenge. Moving the slide. We're talking about the types and challenges, about the chances for improvement. The first of all, the types of hospital 50 beds is it depends of 2 things. One of the best hospital 50 beds, and the second is a lot of challenge there. When we do general services in hospital 50 beds, is a lot of difficulty, a lot of challenging, a lot of the help for health services to improvement. Talking about the challenges, about the chance for improvement. This is our question. How to transform 50-bed hospitals from cost center to profit center? The majority now in all clusters here is the majority is cost center. It's about the manpowers, about the supply, about the recovery for logistic issues. This is the majority of difficulty in hospital 50 beds. So just imagine, can be profit center? Yes. Can be profit center? Yes. What this is the majority of hospital can be, but it depends the type of the hospital, with all challenges and all chances. Just I mentioned general hospital and specialized hospital. What is mean specialized hospital? You know it. The majority of 50 beds should be specialized hospital about the change of scoping. So, if we focus in service that need the village, the people that in village, we can improve in the service, we can decrease the referrals, we can putting as area for excellence. So general hospital at more than third of hospitals and that of general health services. This is the specialized hospitals, extended care hospitals and eyes hospitals. What is the majority of eyes hospital is in the village. About the average age there, what about cataract? Cataract is majority in old age. What the percentage for cataract on the old age is more than 95 in 100%. So why do eye hospitals in the village? Yes, why? Could be eye hospital, but the majority of the patient is old age. So the old age majority is in the village. So why did change the scope there to specialized hospital? Psychiatric hospital. You know that psychiatric hospitals need the area outside the city. for improvement, for healing, for widened within cities. So this area extended hospitals also. This is our challenges and 50-bed hospital about workforce sustainability. Right. Workforce sustainable and limited of health services and geographic distance from the center. Also low population sign, all this our challenge in the 50-bed hospital. What our improvement? One of them is the locations. It's different the village about the locations. What we can do. I told you about specialized hospital. I told you about what the BHM need in this village. The geographic location is important for improvement. The virtual health services is majority to helping. This is mandate for improvement the hospital 50 beds. Activating training center. About the employee there, if no training, active training, running training, will be the health worker, will be the not improvement service, not improvement, not updated. So what I do as a part from the general rotation. So 2 or 3 months each year can be do it in hospital 50 bed. Sharing with regional stakeholder. Yes, we have Aramco site in the village, we have industry in the village, we have also soldier hospital in the village. We have a lot of sharing stakeholder can be improvement. What I mentioned before, this is the important message down, rescope the service based on BHM report in the village. So we should be rescoping, depend of the cluster for improvement. Thank you.
We are now welcoming Dr. Ghazi Dhafiri, consultant internal medicine and pulmonology, and the head of the chest and isolated section in Hafar al-Batin, who will present particular approach to optimize asthma care in rural practice to achieve better outcome. Please welcome Dr. Ghazi Dhafiri.
نقدر نغيرها من هنا ولا لا؟ وين التغيير معلش؟ هنا. طيب. السلام عليكم. شكرا للجنة المنظمة على الاستضافة. I will talk about bronchial asthma. كذا واضح؟ السلام واضح؟ تمام. التغيير من هنا. طيب. The most prevalent chronic respiratory diseases worldwide, estimated global prevalence around 262 million worldwide. 25 million Americans have current asthma, and US prevalence around 7.7 per year. and 62 in USA have uncontrolled bronchial asthma. In our country, Saudi Arabia is around the prevalence 10%, increase in the south, some region up to 15% in the south. Most predominant affected the female adult with dark skin. Just the rural respiratory burden, respiratory diseases are the major issue in the rural area. Higher rate of COPD, impact of indoor air quality, biomass fall, smoking, asthma trigger from dust, smoking, allergen. The respiratory disease the most common in the rural area, secondary to the dust, poverty. There is unique rural risk factor and the challenge in the rural area. Risk factor for tobacco smoking, poor hygiene, indoor air pollution, wood fire, agriculture dust, limited health care access, and proven malnutrition, challenge in diagnostic limitation, treatment access medication, and adherence to the medication, and the education in rural area. We have deficit in the educate the patient, convince the patient you have the disease. This is the asthma background. I bring this slide from our culture, the fire under the ash, النار تحت الرماد. There I will highlight the most important definition in bronchial asthma. It is a heterogeneous disease, not a single disease. It is airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, and cough, chest tightness, vary over the time and intensity, and variable to respiratory air flow limitation. There is visible and invisible feature of bronchial asthma. The visible outcome, it was exacerbation, symptom, lung function, and invisible, it's bronchodilator, hyperresponsive, airway inflammation, and airway remodeling. What's the goal of asthma management? The long-term goal of asthma management, for every disease we have the goal in the management. In the bronchial asthma, we have to reduce the symptom and reduce the risk. Achieve the maintain good symptom control, maintain of normal activity level, and reduce the risk of mortality, risk of exacerbation, and risk of fixed airway limitation, and minimize the side effect of medication. What is the missing is the long-term goal is suppression airway inflammation. Definition of asthma control. Asthma control test. Asthma control test is the 5 question. Each question you have from 1 to 5. The maximum score 25, and the least score is the 5. With high score, you mean the asthma is controlled. With less score, you mean the asthma is not controlled. Asthma control if the score more than 20, and partially control if less than 20 and more than 15. And if the less than 15, this you mean that your bronchial asthma is not controlled. Poor asthma control can impact patient daily life, worse health-related quality of the life, and high symptom burden, great work and activity impairment. Patients have inadequate control asthma in real-world study of 102,000 adults with asthma across 5 European countries report around 76 of the patient is under control. The ACT asthma questionnaire test less than 20. In our country in Saudi Arabia, around 1,000 patients from Saudi Arabia, they report around 70% under inadequate control. Asthma management. This is the SINA guide 2024. It was divided the asthma in the mild, moderate, severe, and according to the severity, we start to the step treatment. Just this is simplified the approach to the asthma. This is for general practitioner and the family medicine. The simple asthma guideline. In the step 1, you can start ICC and formoterol as needed. Low dose in the step 2, low dose ICC versus with LAMA. Step 3, medium dose of ICC LAMA. Step 4, add LAMA to step 3 and single agent. And okay. Just what the new molecule, we have a new molecule introduced in the treatment of bronchial asthma.
with fluticasone furoate, we have 2 times high affinity than the other inhaled corticosteroid, and the imiclidonium, which is long-term LAMA, 24-hour bronchodilation with high affinity and high selected for M3 receptor, and filintrol, which is beta 24-hour bronchodilation with rapid onset and high selectivity for beta 2 agonist. This does study critical error rate may be different between the device. In devices Ellipta, which use in the fluticasone furoate and filintrol, it was show less error, critical error, and around 7 times fewer critical error with Ellipta versus common use the other device. This is one Ellipta device dry powder demonstrate near completely dose delivery. If you saw in the flow rate of respiratory and the concentration of the medication, the Ellipta device is almost completely resolved the medication by the patient, around very high absorption, even with low respiratory flow. With Relifar, 25 more patients can be improved their asthma control versus other ICC LAMA. It was 25% reduction and improve the symptom. Patients maybe have more likely to adhere to the once daily and versus twice daily inhaler. As we know, the Relifar or fluticasone furoate, filintrol use a single agent one time per day. Adherence to the medication 26%. In the asthma exacerbation test, we show decrease by 13% in asthma exacerbation with the single device than the dual or BID medication. In this fluticasone furoate provide long-lasting bronchodilation compared with the placebo, reach up to 24 hours and reach up to 72 hours. Even with ICC LABA, there is some patient he still have inflammatory process, just 2 minutes. Inflammatory 50% he have night symptom, 50% he have day symptom, and 25% of the patient have limitation in activity. Overall, 30% have still uncontrolled bronchial asthma. We add the LAMA in the step 4 to the previous medication in single agent therapy. When you add the LAMA, benefit from the LAMA, improve the lung function, reduce the symptom, achieves asthma control. Okay, this is the mechanism of action of LAMA, prevent acetylcholine from the binding to the M3 receptor and prevent bronchoconstriction. This is the study of Captain study. Compare when they add LAMA to the dual ICS LAMA, show the improvement in the lung function. The triple therapy component, fluticasone furoate, LAMA and LAMA. This is the action reduce the inflammation, inhibit bronchoconstriction, activate bronchodilator in one single therapy and cover for 24 hours. In this study done in over 2,400 patients. This is randomized double-blind study. Divide the patient to the 4 category. The Relifar 100 and 200, and add LABA to the Relifar. And the end point of this study, the improve the lung function. This is the inclusion and exclusion criteria. This is most inclusion criteria. Most predominant is female, more than 20 years. He have a bronchial asthma, moderate to severe bronchial asthma, and he have one exacerbation in the last year. Plus, he have forced expiratory volume less than 60. This is the design of the study. This is the primary endpoint, study endpoint. It's mean the change from the baseline for lung function, and annualization, secondary is annualization rate of moderate to severe bronchial asthma and the asthma symptom. Just what we learned from the Captain study. From the Captain study, both arms with LAMA, add the LAMA, there is decrease improve in the forced expiratory volume, but with 200 improve the exacerbation in 200 arm with Relifar when you add imiclidonium. This the improvement in the forced expiratory volume increase in 110 in the 100 fluticasone furate plus imiclodonium. In the other hand, with 200 concentration increase by 92, which both is effective. The role of imiclodonium patient in control of bronchial asthma, which show is increase in control of bronchial asthma with imiclodonium. And the influence of the additional LAMA on the symptom, the additional LAMA provide clinically meaningful improvement in shortness of breath and chest tightness. This the 62 versus 52 patient improve in pulmonary asthma control for the patient with imiclodonium. And the most exacerbation improve all exacerbation improve with the imiclodonium arm by 22%. This is the information. Okay, it's finished. Thank you.
Our final speaker for today, pharmacist Rashid Aswaya, clinical pharmacist and healthcare product manager at JSK, Saudi Arabia. He will explore the importance of Shingles vaccination in adults age 50 and above and its relationship with healthy aging. Please welcome pharmacist Rashid Aswaya.
منين؟ ايوه اوكي. السلام عليكم 1 2 ممتاز. طيب يعطيكم الف عافيه. Thank you for attending. ان شاء الله we will not take long of your time. I know it was a long day. اليوم راح نتكلم عن الشينجلز disease. So I'm going to speak Arabic and English, so bear with me. First of all, we will talk about herpes zoster shingles disease in 50 plus population and why we need them to be vaccinated and be protected from this shingles disease أو الحزام الناري. فخلينا نتكلم بنقطة أولية، هو كم نسبة الأشخاص اللي عمرهم 50 سنة فما فوق وعنده الفيروس اللي ممكن يسبب الحزام الناري. How many of the patients that you know are 50 plus and above and they have the virus that could cause herpes zoster? Actually, we say that it is more than 50 plus or more than 90 plus of the 50 plus population have the virus that could cause herpes zoster. And why is this percentage is very high? We say that the primary infection of the varicella is the primary cause of latent zoster virus. So the chickenpox or the VZV is the primary cause of herpes zoster. When the patient is prone or infected with the virus, it will become latent in their body, in the dorsal root ganglion. Then it will have an age-related decline in immunity, نقص المناعة بسبب كبر العمر، ثم راح يكون عندنا reactivation للvirus itself. Now the reactivation of the virus itself will become the herpes zoster أو الحزام الناري. So we say that 1 in each 3 will develop herpes zoster in their lifetime. So 1 من أصل 3 will develop herpes zoster in their lifetime. And why we are concentrated on 50 plus? So the majority of the cases, we will have a sharp increase after the age of 50. So after the age of 50, we will have a sharp increase in the herpes zoster cases, and that's why the recommendation from the MOH is to take the vaccine at age 50 or age 18 plus with at risk of getting herpes zoster, such as immunocompromised or autoimmune diseases. Now moving to another specific slide, which is the immunity level. So now you can see that with age, with coming age, there will be a cellular immunity decline that will cause the reactivation of the virus itself. And thus we say that age-related decline in immunity. So we will talk about the risk factors. The risk factor for developing herpes zoster. So when we talked about the 1 in each 3 will develop herpes zoster, this is for healthy individuals. So what about non-healthy individuals? What about someone with comorbidities? Are they at risk of getting herpes zoster? Yes. So someone such as a diabetic patient, hypertensive patient, anyone with chronic conditions such as a cardiovascular patient will have an increased risk such as we see here. Diabetes will have 24 to 30%, 29% for renal diseases, cardiovascular diseases will have 34% increase, and chronic obstructive pulmonary diseases 31 to 40%. So, what is the impact of shingles? As you may know, that shingles is one of the most serious diseases that can patient have. It is one of the painful diseases that a patient can have, and I know that most of you or some of you have had some patient or have some loved one who had the disease itself. So, what is herpes zoster? It is caused by the reactivation of the varicella zoster virus. It is a serious dermatome that could happen in the dermatome region or the dorsal root ganglion region of the patient himself, and he will develop this painful disease. So actually we had a pain level to measure the intensity of the disease itself. As you can see here in the Miguel Pain Questionnaire, it was done to measure the pain level of herpes zoster. And what we concluded that the herpes zoster itself, the pain level of herpes zoster itself, was more painful than the labor pain itself. ألم الحزام الناري كان أسوأ من ألم الولادة نفسه. وهذا في أشخاص أصيبوا بالحزام الناري وأيضا كانوا في حالات اللي هو الليبر pain. So this is what we are talking about. Now what about comorbidities? Yes, there is association with comorbidity patient, such we can see here with patients who are diabetic in nature. 21% of patients who are herpes zoster prone are also diabetic in patient in Saudi Arabia. We will have increased hospitalization, increased persistence in pain, and also increased persistence in comorbidities and complications such as PHN and herpes zoster ophthalmicus. When we see that also there is a relationship between it and the cardiovascular cases, we will have 34% increase in relative risk of developing shingles with CKD. This is all comes to one and important point, that everyone who is 50 plus, regardless of his history, is he comorbid with diabetic or is he comorbid with CKD, he should take the vaccine. So the treatment options for herpes zoster itself, the treatment is for acute herpes zoster antiviral started within the 72-hour period. After the 72-hour period, the treatment is ineffective. After that, we will go with analgesics, opioid. This is one of the serious indications and serious diseases that we will use opioids in. So this is just to highlight the importance of preventing herpes zoster. So let's move to the solution. So if we have this disease and the virus is already in their body, I cannot tell the patient that he can protect himself with a mask or take a detergent or just don't socialize anymore. No, because the virus itself, it's already in them. So what is the best preventable measure that we can do is to vaccinate. So this is the vaccine that we are talking about. It is developed by GSK. It's a recombinant, non-live antigen adjuvant system that allows the protections for the patient to be a shingles-free patient, inshallah. So let's talk in quick successions about the studies that have been done to measure the efficacy of herpes zoster. We have two major studies, ZOE 70, ZOE 50. It was done to measure the efficacy of preventing herpes zoster itself. More than 30,000 participant, multinational, multi-center study, and the result is as follows. So Shingrix developed or delivered 97% efficacy against herpes zoster itself. This is for 50 plus. And when we combine the two sectors, the ZOE 70 and ZOE 50, we will have a combined efficacy of 91%. So 91% for efficacy. What's more? We have also efficacy for 11 years. 11 years of protection. This is also one of the questions that is answered through the slide. Is it an annual vaccine? Do we need another dose in second year or third year? No. The efficacy up to 11 years is 87.7%. Now, one important point, and we need to highlight this, the second dose compliance. Some of the patients that come to the clinic, they don't commit to the second dose regimen. As you may know, that it should be taken from 2 to 6 months, and some of the patients don't comply with the second dose. It is highly important for those patients to take the second dose. أن نقول أن تطعيمة الحزام الناخي الجرعة الثانية هي جرعة تكميلية وليست جرعة تنشيطية. فمهم جدا للأشخاص هذولا أنهم يرجعون عندنا ويأخذون السكند dose. And this is also as part of the recommendation from the MOH itself, is to take the first dose at month 0 and the second dose from 2 to 6 months apart. We will have 4-fold immune response when taken after the second dose. So, safety. Let's talk in brief about safety. Is there any side effect of herpes zoster? Yes. With any vaccine, there is side effects. Injection site reaction, pain, redness, swelling, all was observed in the clinic and the clinic design. But alhamdulillah, there was no serious adverse event, no fatal side effects when we measured it with the placebo group. So they will have some pain, redness, swelling. We can manage this through any analgesics. In 2 to 3 days, the patient will be on a remission state. The most important point, and we need to highlight to our patient, اللي هي إيش؟ ألم التطعيمة ولا ألم الحزام الناري. هذه النقطة very important to highlight. So, storage and administration, RSV vaccine should be refrigerated, do not freeze, 2 to 8 Celsius. The vaccine is supplied in 2 vials. You will have it in a liquid form and a powdered form. It is for intramuscular injection only, and the indication is 50 plus and 18 years of old with an increased risk of herpes zoster. The contraindication is hypersensitivity to any excipient, and the limitation, Shingrix is not indicated for the prevention of chickenpox. So we will have the co-administration. Can we have it in co-administration? As you know that we are leaving the flu vaccine in this month or so. So can we take it with the flu vaccine? Yes, we can take it with the flu vaccine. And also we can take it with pneumococcal, PPV23 and PCV, and also a Tdap vaccine as well. So this is the guidelines from the MOH itself. As we said, it is 2 doses, 2 to 6 months apart, and this is also a recommendation from other countries and other societies as well. We will have the diabetes mellitus, the cardiovascular, American Heart Association, all recommend herpes zoster for their patients. The most important take, and I want to take 1 to 2 moments here in this slide. So 25% of our society are accepting the vaccine. 25% have the acceptability of the vaccine itself. Now, we done a measure to change the behavior, this one. And we found out that with a strong recommendation from a healthcare provider, we can change the 25% to 74%. وزارة الصحة قامت بجهود جبارة لدخول تطعيمة الحزام الناعم عندنا في المملكة، والجهود الجبارة هذه واقفة عند الجهود الجبارة للهيلث كير بروفايدرز اللي موجودين عندنا في المملكة العربية السعودية. We need to extend this support that can come from MOH, Ministry of Health, to change the mindset of vaccine acceptability from 24% or 25% to 74%. Thank you so much.
Ladies and gentlemen, this is conclude day 1 of the scientific program. Thank you for engagement and participation. We would like forward to welcome you tomorrow for day 2, where we will focus on challenges, solution, future strategy for rural health. Thank you all.